Good to go?
Okay.
Good morning, everyone. I'm Jeb Bradley, and I'm from Senate District 3. Today, we will be holding a meeting of the Senate Health and Human Services Committee. Before we get started, I will read through a checklist to ensure that the meeting we are holding is in compliance with the right to know law. As chair of the Senate Health and Human Services Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic and in accordance with the governor's emergency order number 12, pursuant to Executive Order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note there is no physical location to observe and listen contemporaneously to the meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I am confirming that 1, we're providing public access to the meeting by telephone, with additional access possible by video and other electronic means. We're utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access contemporaneously to watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the General Court website. 2, we have provided public notice of the necessary information for accessing the meeting in the Senate calendar. 3, we are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate, that's all one word, remotesenate@leg.state.nh.us, or you may call 603-271-6931. 4, in the event the public is unable to access the meeting, it will be adjourned and rescheduled. 5, please note all votes taken during this meeting shall be done by roll call. And 6, finally, let's start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone is in the room with you during this meeting, which is required under the right to know law. So let me start the roll with Senator Sherman.
Good morning, Senator Tom Sherman, District 24, and I am alone in the room, but there is family in the house.
And Senator Avard.
I'm Senator Avard in my office in Nashua. I just have a couple of animals that'll probably interrupt, but that's about it.
Senator Whitley.
Good morning. This is Senator Becky Whitley from my home in Hopkinton. I am alone in the room, but my family is in the house.
Senator Gray.
I am James Gray. I am in Rochester in my home in District 6, and I'm alone in this room.
And I'm Jeb Bradley, and I'm at Karen's rental property in Rockport, Mass, alone in the room, except for Napoleon, who you can see on the screen. Okay, so having dispensed with the formalities, I'm going to open the hearing on House Bill 600 and recognize Representative Marsh. Good morning, Bill.
Senators, can you hear me?
Yep.
Thank you. For the record, I'm Representative William Marsh, representing 7 towns in Southern Carroll County. And I am pleased today to offer for your consideration House Bill 600 relative to funding newborn screening tests, which I filed at the request of the New Hampshire Hospital Association. New Hampshire's newborn screening program is a wonderful program, and the intent of this bill is not to change the program in any way. The issue that I have with the program is how they send out their bills. Under current law, DHHS bills hospitals for the filter paper on which blood samples are submitted for testing. The cost of this filter paper has doubled in the last year and is expected to increase as more tests are added to the newborn screening panel. Filter paper is a supply, and consequently, this bill cannot be submitted to insurers. There is no charge at present for the test performed. We are simply asking the commissioner to restructure the current fee so that these bills can be submitted to insurers. Instead of billing for filter paper, the invoice could read newborn screening panel. Other states do this. For instance, in the state of Texas, effective January 1st, 2001 and after, HCPCS code S3620 was implemented for newborn screenings. Minnesota uses the same billing code. An American Academy of Pediatrics document about 1 month preventative visits recommends HCPCS code S3620 for newborn screening if not already performed, and a list of CPT codes, most notably V77.7, special screening of other inborn errors of metabolism. Coverage for pediatric preventative services, including newborn screening tests, has been mandated by federal law without copay or deductible since 2014, pursuant to 45 CFR 147.130. New Hampshire insurers have had a very good deal over the last 7 years. This bill does not mandate any change whatsoever in insurance law. As I told House Finance, you should be aware of the alternative solution to this problem. Currently, 45 states, including New Hampshire, pay for newborn screening through fees, although some do supplement the program using general funds. 5 states and DC simply pay for the program out of general funds. In 1/3 of states, at least some general fund revenues support newborn screening. The alternative solution, which would be equally acceptable to the hospitals, would be to appropriate funds for the program and use House Bill 2 to roll the fees back to the reasonable level they were a few years ago. However we address this problem, by addressing it, we will help maintain the economic viability of the various birthing centers in New Hampshire. I thank you, and I'll be happy to take questions.
Are there questions of Representative Marsh? Senator Avard.
Thank you, Senator, Mr. Chair, and Senator Marsh for bringing the bill up. I do have a question. It's my understanding that these strips are being paid for through bundled negotiations. Isn't that correct?
I do not believe so, and the best evidence of that would be that the per diem rate for newborns was not increased commensurate with the increase in fees.
Okay, so in other words, the insurance companies are not paying for the test strips in their bundle, basically their bundle packages that they negotiate with the hospitals. That's what you're telling me.
Their bundled fee has not increased commensurate with the fee increases, and so therefore I would say that there's pretty good evidence that they did not reimburse for that increase.
So within negotiations with the insurance companies or the carriers with the providers, then couldn't they just negotiate this without having to have any kind of legislation?
No, because the hospitals cannot submit these tests for reimbursement until we change how they are billed. Once this bill becomes law, I would anticipate such negotiations would happen, and in fact, they're already happening with the Medicaid program.
And final question, Mr. Chair, if I could. So basically, we're going to kind of go back towards like a fee-for-service type of situation, then, right? Instead of
that would be free for the hospitals and the insurers to negotiate once that we've gotten everybody to the table.
So that is, yes, we're kind of moving back to a fee-for-service type of situation here then.
Depends on what they negotiate.
Thank you very much.
Other questions of Representative Marsh? Senator Sherman.
Just following up on Senator Avard's question about fee for service, this could potentially be bundled into the reimbursement for obstetric services or by the hospital. So there is no prescription for it. How they actually reimburse it, it could be a part of a bundled payment that would be more in line with population health policies or reimbursement. There's nothing in the bill that actually prescribes how this is reimbursed by the insurance company. Isn't that correct?
That is correct, Senator. All this bill does is ask the commissioner to change how the fees are structured so that they can be submitted to the insurers. How the insurers decide to reimburse this, whether they do it in a bundle or whether they do it on a fee-for-service basis, is certainly something that they could negotiate. And I suspect that those negotiations will happen once they realize that they've been brought to the table.
Okay, thanks.
Seeing no further questions. Thank you very much, Bill.
My pleasure. I'll stay on because I have another bill.
Okay. Kirsten, go ahead.
Well, I will, I'll call up Paula Minahan next.
Oh, okay, sorry.
Yeah, no problem.
Good morning, Paula.
Paula? Oh, hold on.
Unmute. Can you hear me now?
There you go.
Yep, go ahead.
Oh, great. Sorry about that. I'm on 2 Zooms and I apologize. I was having technical difficulties. Good morning, Mr. Chairman, members of the committee. For the record, my name is Paula Minahan, Senior Vice President, State Government Relations with the New Hampshire Hospital Association. We're very supportive of House Bill 600, and we do want to thank Representative Marsh for sponsoring this bill, as he indicated, as well as all the co-sponsors. This bill is targeted to how the newborn health screening program is funded, and I will not repeat what Representative Marsh explained, because he did a great job at explaining that basically because the filter paper is 100% paid for by the hospitals. That's how the whole entire program is funded. And all we're looking for is this kind of technical change to allow for this to be more considered a pediatric test, which is covered by federal law. So this is kind of a technical bill, and it is needed for Medicaid, as well as our ability for the hospitals to be able to negotiate with the carriers, the private carriers. Again, it does not change insurance law. It's just allowing for this to be a billable service, if you will. And again, we're not looking to change the program at all. We are 100% supportive of the program, but as more and more screens are contemplated by the Newborn Advisory Council, which is a good thing, that will raise the cost of the entire program. And we're just looking to have an opportunity for the hospitals to recoup some of those costs. I have submitted written testimony. I am happy to answer any questions, and thank you very much.
Questions? Senator Whitley.
Thank you, Mr. Chair, and thank you, Paula, for taking my question. So with the rise in newborn screenings, as you indicated, which is a great thing, it's likely that we'll be able to catch more, the need for more medical intervention early on, correct? And then, that could potentially save costs in the long run. Isn't that correct?
Absolutely. Yes, I 100% agree with you, Senator.
Thank you.
What I can do, I think you will find it interesting, is send you along, I'll send it to Griffin, the state's annual report on the newborn screening program. It's fascinating. And we do screen, I don't know if Dr. Sharella is going to testify, but I believe there are about 31 screens that are done right now, but I will forward that report to you because it's fascinating, and I think you will find it interesting.
Thank you.
Sure.
Further questions of Ms. Minihan? So I have a couple. I understand that the test is actually being analyzed in Massachusetts. Is that correct?
Yes. Again, I don't know if the state is on, and hopefully they are. They can answer specific questions. They have a contract with the University of Massachusetts in Amherst. They are one of very few testing facilities in the country that are able to complete these tests. So what happens is this filter paper is purchased by the hospital, the birthing hospitals. When a baby is born, the test, if the parents agree, they do have the option to opt out. If they agree to the newborn screening, the filter paper will be completed. And then a courier picks it up within hours and gets it to UMass for the analysis, which is then provided back to the state. But there is actually a contract. It goes through governor and council, and I believe it's actually being updated as we speak. But yes, it is University of Mass Amherst, I believe.
My understanding is that a fairly significant part of the cost increases are the courier services. Why is it that no New Hampshire hospital is performing these lab analysis?
They don't have the capability to do these analysis. It's considered a highly specialized specialty lab. So and it's really, I think that's a question for the state senator, because the state does the RFP and has the contract with UMass.
Okay.
I don't know about the courier costs. I did ask for, when the cost was going up, I did ask for a breakdown of the various costs. I don't know that the courier costs is as expensive as actually doing the analysis and the specialists that have to analyze all the testing. But again, this is all can be negotiated with the carriers. But it has gone, it was originally like $40 or so. Then it went up to $71, and it's currently, I believe, $147 for the filter paper, each filter paper. So it is, it's just a significant increase in the last year or so.
Further questions?
Just
Senator Avard.
Just one. Did the hospital association actually contact the insurance companies to negotiate this at all?
Representative Marsh and I spoke with DHHS, and we actually attempted to reach out to the Department of Insurance. This was early on before the bill was actually drafted. We were unsuccessful. We have been talking, obviously, with the Department of HHS and Public Health. And we did reach out to the Department of Insurance. We were not successful in connecting with them. And since the bill was filed, we have talked with AHIP and the carriers.
Senator Sherman. I'm sorry, Senator Avard, did you have another question?
No, so I formally then, no formal conversation has happened with the insurance companies at all, then, is basically what I'm hearing.
Oh, I certainly have had, I have had conversations with them. As far as the individual hospitals, we filed this on behalf of our hospitals due to concerns that were raised by the CFOs.
That's good. Thank you.
You're welcome.
Senator Sherman.
I have just a few quick questions. Hi, Paula. Good to hear your voice.
Good morning.
This testing is part of a state requirement. Is that correct? With an
It's a state law. Yes.
Right.
Yes, absolutely.
Follow up?
Yes.
Yep.
Is there any other testing? Trying to think of how to ask this. Is there any other? So it's required by state law, and the hospitals have to pay for currently have to pay for it because there is no mechanism for them to bill insurance companies, correct?
Because, as Representative Marsh said, currently it is considered a supply. And I think it's just a historical kind of it's kind of historical that the hospitals kind of absorb these costs early on. Most states have these programs, and I can send you the chart that Representative Marsh was talking about. States fund this differently. Some fund them with general funds. Very few do that. Some just have the hospitals pay for it. The cost varies considerably by state. I'm not quite sure why that is, but that is the case. The number of tests that are done vary by state. And so anyway, it's a supply. And I think it's just historically, the hospitals were absorbing this and we're not passing it on. And I have sat down with the hospitals and the birthing centers that are the nurses that are responsible for this to kind of go through and how this is processed. And again, it doesn't work its way into the revenue cycle, if you will. So it's just been absorbed all these years, and it was raised as an issue a couple of years ago. And we started researching this when the price went up. And so what happens is, yes, by state law, the hospitals are responsible, and they were just absorbing those costs for many, many years. But because the cost has doubled in the last year or so, that's when we sat down with the public health department and started talking through what other options there are. And this legislation is a result of all those discussions. We're just trying to figure out a way to recoup some of the costs.
Follow up?
Yep.
So this is best practice, mandated by state law, federally reimbursable by insurance companies. Is there any other perinatal testing that is not reimbursable by insurance companies?
I don't know the answer to that. If Dr. Shrella is on, maybe she can answer that question, or I can find out for you, Senator. But I am not able to answer that question affirmatively.
Okay, thank you.
Further questions, Senator Whitley.
Thank you, Mr. Chair. And just to follow up on Senator Sherman's sort of line of questioning, I think it's clear that these screenings are required by state law. It's clear that Medicaid does cover this, but isn't it also true that Medicaid, under the EPSDT requirements, this is also more than just a coverage issue, it's a mandate on the Medicaid program. Isn't that correct?
I believe that is true. Medicaid currently, because again, it is a it's a supply. Medicaid will be adjusting their reimbursement or their program. Again, if this bill, we're hopeful that the bill passes, then the department will need to go through rulemaking to modify the reimbursement. But yes, I believe it. I think that is a true statement, Senator, that it's a mandate through EPSDT.
Thank you.
Further questions? Seeing none. Thank you very much.
Thank you.
Let's see, next up I have Sabrina Dunlap.
Hello.
Good morning, Sabrina.
Thank you. Hi. Thank you, Senator Bradley and members of the committee. I'm Sabrina Dunlap, Director of Government Relations at Anthem. Thank you for the opportunity to testify. We are opposed to HB 600. We have several concerns with the bill. So first of all, we support the newborn screening program. I just want to be clear about that. But we don't understand the need for this legislation. We had no knowledge of this bill or any issues with testing strips when the bill was introduced in the House. And since the issue of how testing strips are covered is an issue of contract negotiations, I asked our contracting folks if they had any knowledge of this, and they said they did not. So the bill was really the first we'd heard of this. So when I testified in the House, I said we were quite puzzled by the bill and struggling to understand the purpose. And that continues to be the case. The premise of the bill is puzzling because testing strips are a supply. They're covered as part of the bundled payments we make for childbirth. And generally we negotiate an all-inclusive bundled payment with hospitals that includes supplies like the testing strips. So we don't pull out other individual supplies in a fee-for-service model. And so it seems very odd that we would do so here. And, you know, this is not a positive direction in terms of public policy. Healthcare in general has shifted. It continues to shift away from fee-for-service payments and toward value-based bundled payments that are focused on a holistic view of patient care and patient outcomes. And I think bills like this move us backward by pulling out this very specific supply and saying through legislation it should be covered in a fee-for-service model. I just don't think this is the direction we want to be headed in New Hampshire. I don't think it's good for healthcare. And just to respond to a earlier testimony, we just don't see the need for legislation in order for us to negotiate this issue. And again, I want to be very clear, this was the first we had heard of this as sort of rising to this level. And so I think any issue with the testing strips can be remedied outside of the legislature. And I hope we'll be given the opportunity to work on this in a non-legislative setting. So thank you very much. And I am happy to take any questions.
It must be that phrase non-legislative setting that triggered Sherman's question. Go ahead, Senator Sherman.
Thank you. That would be spectacular, except that the requirement that the hospitals pay is in statute. So the question here is who pays for this? So hi, Sabrina, thank you so much for coming. And my question would be, where in the bill does it require this to be a fee-for-service reimbursement scheme on the part of the insurer? Why can't it be part of the negotiated bundled payment?
Well, thank you for the question. I think it can be and should be part of the negotiated bundled payment. And so I guess it gets to the issue of why do we need this legislation for us to move forward in that manner? I think that, go ahead.
No, I'm just going to follow up when you're done.
Oh, I was just going to say that the notion of the bill really kind of pulls out this specific supply. And we've heard, I mean, we consider it a supply. You heard already that others consider it a supply. And so it just seems very odd that we pull this specific thing out. And so just the nature of the bill sort of suggests that it would be treated in a fee-for-service manner.
Follow up?
Yep.
So this very specific thing that you're talking about, which is the supply, or, you know, since if I do a rectal swab, which we do in my practice, and I send that off, that's a bundled payment. The supplies that are used, but it's part of a lab test, which this is also. So I don't know why you keep calling it a supply when it's actually part of a laboratory test. But currently it's in statute. My understanding from Paula's testimony, it's in statute that the hospitals have to pay for this. And I'm wondering why we shouldn't fix that statute and say that this should be part of the, that this should be something that should be part of the payment to, for services at the time of childbirth. So I guess my question is, if you're saying it would be unusual for us to do this, then the current situation is already unusual and needs to be remedied, which would leave us with three options. One would be to put this in covered by the general fund. Two would be to keep in statute that hospitals have to pay, or three would be to do what we do with all laboratory testing and say that this should be part of the relationship between hospitals and insurance companies, which is, I think, what this bill is trying to do. Wouldn't you agree with that? It's not all that unusual, especially since we're starting from a place of unusuality, which isn't a word.
Well, thank you for the question. And I would just note on the supply point, I mean, I think we just heard Paula Minahan say under Medicaid, it's considered a supply. I talked to our contracting folks. They said they certainly would consider this a supply. And so there's that issue. But to your point about sort of the three options, I agree. I think we all agree that number three is the way it should be, that it should be part of the negotiations for bundled payments for childbirth. And so I guess I still just don't understand why this legislation is needed for us to move forward. Again, I think it's a little bit odd. We had not heard of this before the bill went in. So we have had subsequent conversations with Paula Minahan, which has been helpful, but I just think I still don't understand why the bill is needed for us to move forward with that option 3.
Senator Avard.
Thank you. So you just said that currently these strips are basically considered by Medicaid as a supply?
I was just repeating, I have not actually double checked understanding, and that is what I heard Paula Minahan say. So I think, and I know that that's my understanding from our contracting folks, is that the strips would be considered a supply.
Just one quick follow-up. If we move forward with this bill, does it set the stage for future teasing out of areas where, well, maybe we can consider a bill for this and have a fee for service for this or a fee for service for that? Does this set the stage to go back to where we just came from?
Thank you for the question. I mean, I think it does. I find this whole situation odd, as I've said. I think that it is an example where, had we known about it, we could certainly have worked on this outside of the legislative setting. I do think it's a little bit odd to put a bill in for a specific supply and a specific service. And so I don't think it's moving in the right direction. And I do think it can be resolved outside of the legislative space.
Thank you.
Okay, thank you very much. Griffin.
Next I have is Andrew Hosmer.
Who? I'm just kidding. I'm just kidding. Kidding, Senator. Sorry. Thought I had to do that.
Good morning, Andrew.
Good morning. Thank you very much. Hopefully you can all hear me right now, and I appreciate the opportunity. For the record, Andrew Hosmer representing Harvard Pilgrim Healthcare. And I don't want to be repetitive, but I do want to say that Harvard Pilgrim Healthcare opposes this bill, but we fully support the newborn screening program. We know that these tests are a very important tool in our healthcare system. Harvard Pilgrim and other health insurance companies make a bundled payment to hospitals to cover all costs related to births, including the cost of supplies. This bundled payment is the subject of negotiations during contract talks with the hospitals. To our knowledge, there is no law that prohibits hospitals from including these supplies when they negotiate the bundled payments for births, and certainly all along, Harvard Pilgrim felt that it was included in the bundled payment, and they were compensating for this item. We certainly assume that the hospital finance teams have examined all of the costs, including costs for supplies, when they enter the negotiation. So the claim made by the bill's proponents that insurance companies have not been paying for these tests seems a little far-fetched. And just to conclude, I'll certainly echo what Ms. Dunlap said. We were first made aware of this issue when legislation was filed. Had we been made aware of it prior to that, certainly the nature of our relationship with all of the providers is to have good faith and work towards fair compensation for the services that they are providing. So had we had the opportunity to do that, I think this is something that probably could have been worked out without legislation. And certainly if that's an opportunity here, we're willing to continue working on that. That would conclude my comments, and happy to take a question.
Senator Sherman.
Welcome, Senator.
Thank you.
I understand that it sounds like all of the carriers were taken by surprise, but since it's made its way through the House, I think we're all well aware of this bill now. So my question is, would you be amenable if there was, since everybody seems to be opposed to the idea of telling people what to do through statute, if we removed the requirement that the hospitals pay for this, would you be opposed to that and just leave it up to you? And because right now, if we leave it in statutes, the legislature is telling the hospitals they have to pay for this. And So the remedy here is to say, well, no, the hospitals may not have to pay for it if they can get the insurance companies to be a part of the equation. So leaving the statute the way it is a government mandate to tell a private entity that they have to pay for something, which I know there are several senators on this call who would oppose that, or at least they've been on the record as opposing that in the past. Would you be amenable to fixing the law so that at this point, it doesn't require hospitals to pay for it, but does allow for negotiations for that payment?
Thank you for the question, Senator. And I think it's a very fair question. In some respects, it seems like we're going after the symptom and not the underlying cause of the problem here. So if there's an opportunity to address the statute, the mandatory aspect of the statute, then I think that might be a better option in creating a solution and making sure that the hospitals are provided fair compensation, and it's part of an aspect of negotiations between the carriers and the hospitals. But I think that's worthwhile.
One more question, Senator.
Thank you, Senator, Mr. Chair. So would you be amenable to a potential amendment that would say that the hospitals, that payment for this could be a negotiated process among the providers and the carriers?
Yes, be happy to take an active role in helping draft an amendment and offering our input, but I'm very happy to work on that. Yes.
Great, thanks.
Thank you.
Mr. Chair.
Okay, thank you very much. Griffin,
Next up, I have Heidi Kroll.
good morning.
Good morning, Mr. Chairman and members of the committee. Can you hear me okay?
Yes.
Yep.
Wonderful, great, thank you. Good morning. Thank you for the opportunity to testify on House Bill 600 relative to the funding for newborn screening. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm testifying today on behalf of AHIP, which is America's Health Insurance Plans. Let me start out by saying, and you've heard this from the other carriers, but AHIP and its New Hampshire members fully support the newborn screening program. We understand the value of these tests and the important role that they play in providing quality care to infants. With that said, we do have some concerns with House Bill 600 and do not feel that the bill is necessary, as we think there are non-legislative solutions available to address the concerns that have been raised. And you've heard this from other speakers. And so again, just to kind of recap what the program is, the New Hampshire hospitals buy the filter paper or the test strip from HHS. And a nurse pricks the baby's heel and the blood goes onto the test strip. The test strip is couriered to UMass, which performs the testing in their lab. The lab results are sent back to HHS and parents are notified if there are any issues are identified. So again, the total cost of the program is covered through the sale of the test strips, and there's no cost to the state. And I would say that, we're not aware of any prohibition on the hospitals negotiating that recovery of some of those costs through their negotiations with the carriers. So the supporters of the bill, as you know, have testified that the hospitals and the birthing centers are not able to bill the insurers for the test strip, which again is a supply used by the nurse. And therefore, the claim is that the carriers have not been reimbursing for the test strips. And so under this bill, a commissioner of HHS would somehow restructure things so that the test is relabeled as a lab service for newborn screening rather than a supply. And then the hospitals would submit the bill to the insurers, using certain billing codes. And so, as you heard from Anthem and Harvard Pilgrim, from the carrier's perspective, we believe we have been paying for the test strips. And again, the reason is that insurers make a bundled payment to the hospitals for a birth that reimburses the hospital for all supplies and staffing during the episode of care for the mother and the baby. And then these bundled payments are negotiated by the hospital with the carrier. And also, as you've heard, carriers and providers have been moving away from fee-for-service arrangements and embracing alternative payment structures, such as bundled payments, as a way to focus on quality of care while still controlling cost. So, we, as you've heard, we do take issue with the claim that we've not been paying for the test strip, because we believe that reimbursement for this supply, along with all of the other supplies related to the birth, has been included in the bundled payment. And again, we're also concerned that the proposal, as it's not explicit, but it's kind of implicit in the way the bill is written, would take us a step backwards, back to the fee-for-service model. And that would be troubling in terms of seeing a trend where providers start to try to tease out certain things out of the bundled payments and revert back to fee-for-service payments, and that, in our opinion, would not be a good public policy for New Hampshire. We're also concerned about the bill's requirement that HHS restructure the program so that the test strip, which again is the supply used by the nurse when the newborn's heel is pricked, is relabeled as a lab service, which the hospitals want to bill the carriers for, even though the hospitals are not performing any lab services. It's UMass performing the lab services. So, hopefully you can appreciate kind of the concern and where we're coming from. We believe we've been paying for the test strip and the nurse's time to prick the baby's heel as part of the bundled payment. Now suddenly that test strip or that supply is going to be relabeled as a lab service and billed potentially in addition to the bundled services by the hospital, as if the hospital performed the lab service when in fact they didn't. And as you've heard from the other carriers, we do believe there's a non-legislative solution, and that would simply be for the hospitals to bring up this concern about the increasing costs of the test strip during the contract negotiations with the insurers, or even prior to that, just that contract renewal, pick up the phone and call the carriers. We're fortunate that we live in a small state like New Hampshire where we can do that. And, as you heard, we weren't aware that this was a problem until House Bill 600 came forth. I did subsequently reach out to the Hospital Association, and as Paula Minahan said, we've had a conversation with her. But now that we know, now that the carriers know that hospitals are concerned about this issue, it's certainly a topic that can be brought up in the contracting discussions between the carriers and the hospitals about the bundled payment rate. And, I think carriers are more than happy to do that. So in short, we don't believe that legislative intervention is necessary, and we'd be happy to work outside of the legislative setting to resolve this issue. So I thank you very much for your time and consideration, and I'd be happy to try to answer any questions.
All right. We're way behind schedule, so one question, Senator Avard. Quick.
One question. So there was a suggestion, Heidi, of removing the requirements for the hospitals to pay for it. Does that solve the problem, or does that just kick the can down the road?
I'm not sure, Senator. I'd have to see exactly what that, where in the law that's being fixed. Like I said early on, I understand that the hospitals are paying HHS for the test strips, and I understand that that's kind of the mandate in the law. So I understand that connection. But again, I'm not aware of any prohibition that, that prohibits the hospitals from including this in negotiations with the health insurance companies when they negotiate reimbursement. And from our understanding, we thought that we've been paying for it because a test strip is a supply, just like any other supplies that are part of the birthing, that episode of care, if you will. So that's the piece where I'm not aware that there's a prohibition that the hospitals can include that in their negotiations with the health insurance companies.
Okay, thank you very much, Heidi.
Thank you.
I think the only witnesses we have left are from the Department of Insurance and Health and Human Services. So we'll recognize Tyler Brennan next.
Thank you. So good morning. Tyler Brennan, Life and Health Director with the Insurance Department. And we've been following this for some time. The first thing I wanted to address, though, is the exchange with the hospital association. They had reached out to me in September, and I went back to check my emails, and that was September 30th, in which the department expressed our concern with the legislation and the mechanism. So I remember talking to Paula after that. Not sure if perhaps there was some communication that was missed later, but in terms of the actual question that Senator Avard asked was whether or not the hospital association had engaged with the carriers. The department can't represent the carriers. So I think that's kind of the first thing I wanted to address. The second thing is, you know, I'm looking at this and I'm listening to the testimony both today and at the House, and there seem to be a number of problems the legislation is at least intending to solve that I'm not sure it's going to. In fact, I don't think it will. While everybody kind of looks at the legislative intent when these bills move forward, it seems to ignore kind of the real negotiation process that already takes place between a carrier and a hospital. And typically those negotiations start with, well, you know, we paid you this much last year and hospital's looking for 7%, the carrier's offering 2%. They come someplace between the two. So to suggest that, you know, the test strips should be stripped out and paid for separately, I mean, if a hospital were to take that position, the carrier's response might be, okay, well, we're going to offset that 3% we agreed to by a fraction of a decimal point in order to make up for the additional amount of test strips. I think the other assumption is that the carriers are always paying bundled payments, and that can mean a number of different things. When I hear that, I think of the DRG payments. That's a Medicare-based reimbursement system that pays a per case amount. And the idea with that is get away from sort of revenue centers associated with all these individual services, lab, medical, surgical supplies, et cetera. Encourage the hospital to use fewer of those things, pay the same case amount regardless of how many services are billed. So I think this kind of service would fall under that sort of arrangement, but it doesn't mean the hospital couldn't be paid on discounted charges. There couldn't be some sort of outlier criteria. In my personal experience, there's even been examples of where cardiac stents, pacemakers have deliberately been excluded from bundled payment because they're very expensive add-ons that need to be addressed independently. Of course, the Medicare systems are designed for Medicare populations. It's always worth taking a look at whether or not an outlier criteria is appropriate. So looking at kind of the cost of the test strips and recognizing that, you know, the increase is substantial, they're pretty small compared to what's going on in the rest of the healthcare system. So it's a little confusing, I guess, in terms of the end game on this, which I've heard even that, you know, one of the interests is maintaining obstetrical services in different communities, which again, I just don't think we're going to get there with this kind of bill. But as has been indicated, it's not an insurance bill, but it does suggest a legislative intent to do something differently, and it does sort of lend itself to kind of an unbundling of services. So we do have some concerns there. We don't have a position on the bill, but happy to take any questions you might have.
Senator Gray.
My question has to do with the cost of the test strips. Does the state add any overhead costs for the state employees to that when they do the calculation? And was that calculation done by you or HHS?
So it's not done by the insurance department. So I'm going to defer to DHHS in terms of how they build it, but most likely it does represent more of a cost structure that may include an administrative component. But I think it's, you know, the other distinction I wanted to make hearing the testimony is sort of who's paying for the test. I mean, if a hospital's ordering supplies, cardiac stents, whatever it is, they're buying those services. They may buy lab services or something else from another vendor and then in turn bill an insurance company for it. So I guess I get a little confused when we talk about who's paying for it. And at the end of the day, it's obviously the premium payers that are paying for these things, but it goes to the carrier, to the hospital, and may go to an independent lab or other third party. But in terms of DHHS's actual charge structure for the test and the test strips, you'd have to address that independently. I'd also like to say that the code was referenced, the S3620, which is described. I did look it up while we were sitting here today, and it says newborn metabolic screening panel includes the test kit, postage, and laboratory tests specified by the state. So it's actually quite a clear billing code. I'm a little confused, I guess, why it wouldn't be used already today, but that's maybe another discussion.
Thank you.
Are you good, Senator Sherman? One question, quickly.
I said I'm all set. Thank you very much.
Okay, all right. So I think that Courtney Tanner had indicated a willingness to speak, but I believe she no longer needs to. So we'll go to the last witness, Henry Lipman.
Good morning, Senator Bradley, members of the committee. I hope you can hear me okay.
Yep.
I guess I'd like to make one point that hasn't been made. I know you're running short on time, and that the department's in support of this bill. There's a bigger issue here that since this bill has even been introduced, one more obstetrics facility has closed. The options available for women to give birth in the state are diminishing by the day. I have a call later this week to deal with another facility that's considered closing that would create a major network issue. This isn't going to solve the problem per se, but it's a step in the right direction because honestly, Medicaid alone can't hold up the entire obstetric network. And, if this bill passes, it's going to contribute towards moving in the right direction. It's not going to solve everything, but it is, as Tyler pointed out, it is a billable test. It's basically restructuring it. So it is a billable test. And what I heard in the testimony is that it can be negotiated. It is nothing that's prohibiting in this bill to be negotiated. Medicaid's going to approach it by making an adjustment to our bundled payment to incorporate that. Thank you.
Great. Thank you very much, Henry. Senator Whitley.
Thank you, Mr. Chair. Thank you, Mr. Littman, for taking my question. We actually talk a lot about these obstetrics deserts in New Hampshire. And isn't it true that the lack of service for obstetrics is particularly problematic in our the rural parts of our state?
Yes, and that honestly is where have a call later this week again. And we've had discussions with the insurance commissioner and the Department of Health and Human Services commissioner about the problem, and that while Medicaid can provide additional supplemental payments to support it, there's a limit in terms of what we can do under law, and it's not going to be enough to keep places open.
Thank you.
Okay, seeing Senator Sherman.
Thank you, Mr. Chair. Quick question. Thank you, Director. You've said that this would allow you to expand in coverage. When we listened to the insurers and the carriers, they had assumed that this was already covered in their bundled payments for the cost of delivery. Is that not the case in terms of Medicaid? So this would be something that would be able to be to bring increased reimbursement to the state through the Medicaid program over what you currently are able to reimburse hospitals for.
Thank you for the question. I think whether it is or it isn't is missing the major point, which is that our obstetrics units are that we have left are in danger of closing in some instances and creating, as Senator Whitley talked about, further desert, if you will, of where you can deliver a baby. And again, I think this is just a small piece of what needs to be worked on in the state to preserve access.
Senator Avard.
I'll wait until we exec. Thank you.
Senator Gray.
Just repeating my question that I asked of the insurance department, is you're the department that does the calculation for this, and are there state administrative fees added to that?
It's just the Division of Public Health that does, but I would suspect, Senator Gregg, that it's limited to the cost the state incurs. I don't know if Cy Shirella could answer that specifically, but there wouldn't be necessarily a reason why we'd be adding to that other than the costs that we're incurring.
Thank you.
Okay. Seeing how far behind we are, I want to close the hearing, but before I do, I will say this. I think the insurance companies have made it very clear that they understand it's their responsibility to reimburse for these tests. I would suggest that between now and May 12th, which is the last day that the committee has to exec this bill, that the companies and the hospitals and the two departments try to negotiate something that resolves this issue in terms of the payment. I believe that the mandate should stay on the books. Please don't remove that, because that could lead to more problems in the future with people not having, babies not having the test done. I think that needs to stay part of the picture. So I'm going to close the hearing, but send you all off in a room to come back with a compromise that we can all support. Okay? Eva, is that clear? Good.
Thank you.
All right. We'll close the hearing and we're going to move to House Bill 582. I'm going to ask Senator Gray to take over for about 3 minutes.
All righty. So we will, are you ready to call on the prime sponsor?
Yep, Representative Mary Beth Walls, I'll bring her right in.
Thank you, Mr. Chairman. For the record, my name is Representative Mary Beth Walls. I represent District Merrimack 23, which is the towns of Bowen, Dunbarton. This bill I'm being brought actually coincidentally on the behalf of two constituents, a patient or the mother of a patient and a doctor, both of whom were my constituents and brought this problem to me at about the same time. What the bill does is it extends the length of prescriptions that may be written for ADD, ADHD, and narcolepsy drugs from 60 days to 90 days. Which that means for the patient is this goes from 6 copays to 4 copays a year. And that's important because copays are not prorated. So these people are paying an extra amount a year by having to pay the extra copays. And in fact, some insurance companies will not write it or accept a 60-day prescription. So some of them you have to go all the way down to 30 days. There's a short, these bills are written by, or I'm sorry, these drugs are prescribed by psychiatrists. And there is, as we all know, a shortage of psychiatrists in the state. So this saves time for the doctors because it means that they're writing fewer prescriptions and it gives them more time to do what they need to do. It's also inconsistent with all the other drugs patients are taking, and including more dangerous drugs. Drugs like Xanax are on a 90-day prescription. We don't really know the history as to why this is on a 60-day. I suspect this has to do with the opioid crisis and people trying to sell these drugs. But you'll hear testimony from Dr. Call that it doesn't matter whether you give somebody a 60-day prescription or a 90-day prescription. If they're going to sell them, and they're selling them. If they're not, they're not. That extending this is not really going to up the problem of having people trying to sell them. One of the other problems with this is that, particularly for ADHD, this is a particularly difficult illness to require extra prescriptions for. By the very nature of the illness, these people are not great at executive functioning. They are disorganized. By asking them to be organized enough to have more frequent prescriptions written to them, and in some cases, with some companies, they have to pick them up personally. This actually exacerbates the problem and makes lack of compliance with drugs even more likely. So by extending the time between refills and requiring fewer prescriptions, you're not only saving them money, but you're helping them stay organized and stay on their drug protocol. This bill sailed through the House, and when it was introduced in the House, it did not include narcolepsy because I was only asked to deal with ADHD. The array of doctors on House HHS said, well, if we're going to do one, let's do both. They amended the bill to include narcolepsy, which I think is a great idea. It came sailing out of committee unanimously. It was voice vote on the consent calendar on the floor, and it's in your lap. I too am cognizant of the time. I'm going to stop right there and tell you that both the patient, mother, actually Joanne Fortier, and the doctor involved, Linda Call, I know are signed up to speak. So if you'd like to hear from either of them, they're both available. And I'd be happy to take any questions if there are any.
Questions from the committee? Seeing none, thank you very much. We can call the next witness.
I have Joanne Fortier. Joanne, you just have to unmute on your end. Joanne? If it's all right, Senator Gray, we can come back to her and I can call on.
Okay, if you would call Joanne offline and see what a problem is if you can.
Yep.
All right.
Let's see.
Hi, this is Dr. Linda Call. Good morning, Senator
morning.
Bradley, members of the committee. I very much concur with everything that Representative Mary Beth Walls said. In addition, I would say, it's important to know that the benefits of treating consistently someone with ADHD that's a critical importance. What we know is it also reduces the likelihood, say for adolescents and adults, speeding tickets, car accidents. It's important to have these meds available with the least amount of challenge. It's absolutely true. There's an enormous shortage of child and adolescent psychiatrists, and that's part of what got me to go back to med school later in life, was seeing this enormous shortage and no place for folks to go to get appointments. If some psychiatrist will only write the prescription in person, then they have to see these patients that may not need to be seen that frequently in 60 days, which takes up an enormous amount of precious time that could be used to open up to other patients. So I think, for a number of reasons, this, for financial reasons for the folks in New Hampshire, as well as I really believe it would be doing absolutely the right thing, and there's really not a downside to it. I think this is the way to go.
Questions of Dr. Call? Seeing none, thank you very much, Doctor. And can we get back to Joanne?
Try it right now. Joanne?
Good morning.
Good morning.
My son, a teenager, takes medication for ADHD, and currently we have a 30-day mail-in prescription. So that requires us to get a new prescription every 30 days and to pay that copay every 30 days. And whether he gets a 90-day prescription or a 30-day prescription, he is going to get a full year's worth of medication. And we do secure that medication so that it doesn't get into the hands of someone who might abuse it. So we don't see that there's any reason or any worry about having a 90-day supply on hand versus having a 30-day supply on hand. It is a medication that helps him immensely. He's a very smart kid. And so we support this bill and ask that it be able to be a 90-day prescription. Thank you.
Questions from the committee? Seeing none. Is there anyone else on the list?
Senator Gray, I don't have anybody else signed up wishing to speak. If there's anybody else who'd like to testify, please raise your hand or press *9 on your phone. And we have the New Hampshire Child Advocate who'd like to testify.
Good morning, Moira O'Neill. Can you hear me okay?
Yes, we can.
Thank you so much. Good morning, Chairman Bradley and Vice Chair Gray. Thank you for taking my testimony this morning. I'm sorry I was called away for a phone call from another senator, so I didn't hear all of the previous testimony. I just have a few short things to share. The Office of the Child Advocate does support House Bill 120 and the context to consider in which children are medicated with complicated drugs is that they are away from home. And they don't have the diligent attention that most children receive from their parents. So while New Hampshire is fortunate to have really dedicated community of careful foster parents, there's also fostering includes the over 300 children who are in residential programs here and across the country, many without professional staff monitoring medical care. So, we really feel strongly that this careful oversight to ensure the best quality of care is absolutely necessary. We worked with the New Hampshire Psychiatric Society on several suggested amendments to this original bill, and many of them were completed in what you're looking at now, but there was one little piece that wasn't included, And that is the standard of care, which calls for a full medical assessment and psychosocial assessment. It was inserted in 169B23 governing adjudicated delinquents, but it wasn't inserted in 169C34 governing the department's responsibilities under child protection. So we would recommend that the bill be amended, and that would be on page 2, line 4. We would recommend inserting the paragraph that's proposed on page 1, lines 16 to 22, starting with prior to prescribing. It's just really important, and I think you'll agree that that there be a full assessment of a child's health to fully understand the behavior for which they're being treated. You know, children in DCUF custody are predominantly children who are victims of abuse and neglect and other family dysfunction. They have high ACEs scores that are associated with mental illness and communication disorders that manifest as problem behaviors. And even removal from home is generally an adverse childhood experience. So when treatment is prompted for these persistent symptoms, it's really best to understand where they're coming from. So the standard of care is a full medical assessment and also a full psychosocial evaluation, so that psychotropic medications are never given instead of, but in addition to other treatments. And the last thing I would mention for your consideration is a proposal that we made to enhance the capacity for prescribers and oversight of psychotropic medications in New Hampshire. You know, as well as we, that there's a persistent shortage of child psychiatric providers. In our original recommendations for this bill, we included a resource for primary care providers who were willing to prescribe if they got the right guidance and education, so that they could become familiar with these medications and how they work. There's some really great models to support pediatric primary care providers who are willing to prescribe. We note the Massachusetts Child Psychiatry Access Project, which is a remote consultation and educational support for best practices. This would be a resource not just for kids in foster care, but for children, all children in need in New Hampshire. And we have seen, I know many of you have been following the problem of children backed up in emergency rooms. We have noticed that some of them are ending up in the emergency rooms because they need medication adjustments. And so this is something that would address many levels of problems with psychiatric meds. I presume that it wasn't included in the amended bill because there would be a related fiscal note, but it's certainly something to mention for your consideration, either for now or in the future. So for those reasons, we do support the bill with the slight adjustment, and thank you for your testimony. I'm happy to take questions if you have them.
Okay, before there are questions, I believe, Ms. O'Neill, that you are testifying on House Bill 120.
Yes.
Not 582, and we're still in the middle of the hearing on 582. So rather than testify again, I think just when you go to do the hearing notes, Kirsten, just utilize that. So what I'm going to do, Ms. O'Neill, I'm going to ask that if there are any questions of you when we get to 120, I'll recognize you again, not to re-give your testimony, but to answer questions.
Thank you very much for that. And my apologies, I got so distracted with another call
What
that.
happens with remote,
appreciate
it's no one's fault.
Thank you for your patience and your flexibility.
Okay, no worries. Are there, Griffin, are there any other witnesses on 582?
I'll be quite honest, we had a lot of hands up, but now they're all back down, now that I think everybody knows what bill we're on. So I think we're clear.
Okay. All right, then let's close the hearing on House Bill 582. Senator Gray did a much better job on 582 than I did on 600, moving us along. So let's go to the next bill, which obviously is House Bill 120, and we'll start with the sponsor, Representative Marsh.
Thank you, Senators. It's good to be with you again. Can you still hear me?
Yep.
Very good. For the record, I'm Representative Marsh, Carroll County 8, representing 7 towns in southern Carroll County. And I'm pleased to bring to you today House Bill 120 relative to the use of psychotropic medications for children in foster care. And I want to thank Senator Whitley, who helped draft the original version of this bill a couple years ago. So she's quite familiar with it. This bill was filed in response to the United States Inspector General's September 2018 report. Treatment planning and medication monitoring were lacking for children in foster care receiving psychotropic medication, which I have also emailed to the committee for the permanent record. Note especially page 23, which summarizes specifics relevant to New Hampshire, and which I emailed you separately for convenience. What the Office of the Inspector General did is review Medicaid claims data and clinical records in the 5 states which reported the highest percentages of children in foster care receiving psychotropic medications. New Hampshire is number 3. It did this because the Administration for Children and Families is responsible for awarding federal funding to states' child welfare programs and for overseeing those programs. And it reminded us on page 3 of its report that if ACF finds that a state is not in substantial conformity with its state plan, it has the authority to withhold a certain amount of federal funding. What the Inspector General found is that 23.4% of New Hampshire children in foster care receiving psychotropic medicines had no treatment plan. 37.9% had a treatment plan, but no diagnosis. As a doctor, I am most troubled that the total of these numbers is 61.3%, meaning that the majority of these kids in New Hampshire had no diagnosis. And 21.8% of these kids did not receive medication monitoring by a prescribing professional. House Bill 120 is actually a pretty simple bill. It defines medication restraint as the use of psychotropic drugs without a clinical diagnosis and applies the existing law in RSA 126U to such use. Medication restraint is specifically referenced in RSA 126U:1 Roman 4. So long as medical practitioners are treating disease, or in other words, list a diagnosis, this would never apply to legitimate medical treatment. This is similar to how we limited the use of psychotropic medicines as a restraint in hospitals and nursing homes a generation ago. Mike Skivvy has discussed with me concerns regarding the phrase, unless it is to ensure the immediate physical safety of persons where there is substantial and imminent risk of serious bodily harm to the child and others, found in 4 locations in the bill. This was part of the House Committee amendment. I agree with him that this creates a large loophole, and you may want to amend this language. I further believe that RSA 126U:5 covers emergency, and therefore this phrase may be actually unnecessary. California passed a similar bill tightening oversight over the use of psychotropic medications in foster care in 2015, and it has resulted in a 45% reduction in antipsychotic prescriptions to foster care kids and a 73% reduction in prescriptions for multiple psychotropic drugs. The Inspector General on page 31 of his report said that New Hampshire spent $1,741,000 for psychotropic medications for foster care kids in 2016. While this bill lacks a fiscal note, I would contend that a similar reduction in New Hampshire would result in a $783,000 savings to the New Hampshire Medicaid budget. I thank you, and I'll be glad to answer questions.
Thank you very much, Representative. Seeing no questions.
Thank you.
Why don't we go right now to Ms. O'Neill, and if there are any questions of her, this would be the time to do it. Are there questions of Ms. O'Neill? Senator Whitley.
Thank you, Mr. Chair, and thank you, Maura. So you had mentioned a potential amendment related to the requirement of an assessment, which is the standard of care. Can you, for the committee, can you forward your proposed language?
Sure. Thank you, Senator. I do have it in my written testimony that I have submitted to you online. So, and we're happy to help with that. Feel like it's just a matter of adding the same language that's in one section to the other section.
Thank you.
And that is, I think you said page 2, line 4.
Yes, where the language is right now in under 169B, it's on page 1, lines 16 through 22. And so on page 2, line 4, there's a new paragraph, and we would just add it below that.
So it would go after Roman 9
I believe.
on
so.
page 2.
Yes.
And just
Okay.
a follow-up, if I may.
Yeah, go ahead.
And just so I understand, that would sort of make it consistent with some reforms done in the child protection, children's behavioral health system to match, services with an actual assessment. So that's the same thing here, but for prescription of psychotropic drugs. Is that correct?
Yes, correct. Thank you. So, and it is added under the delinquency statute. I think it just was neglected under the child protection statute. And it does, so the psychosocial assessment, most of what's happening now with your expansion, especially from Senate Bill 14, is that kids get that assessment anyway. We are finding that there have been a number of children in the care of the state who were receiving psychotropic medications. And it was later discovered upon prompting for further medical assessment that there were underlying medical conditions, for example, electrolyte imbalances, a thyroid issue, those things. It's always best practice to do a full medical workup first before prescribing psychotropic medication. So this is just a prompt for that standard of care.
Thank you.
Thank you.
Okay. Thank you very much, Ms. O'Neill.
Thank you, Senator Bradley, and thank you for your patience.
No worries. It's a factor of the remote hearings.
Senator, the only other person I have wishing to speak is Michael Skibby, who has his hand raised.
Good morning, Mike.
Good morning. Thank you, Mr. Chair and members of the committee. Mike Skibby, I'm the Policy Director of the Disability Rights Center of New Hampshire, testifying in support of the bill. I want to thank Representative Marsh for his sponsorship and Senator Whitley for the work that she did with Representative Marsh and stakeholders in preparing the bill, and for the co-sponsorship of you, Senator Bradley, and you, Senator Sherman, as well. I won't go on at length, but I do want to address this issue of the definition of medication restraint that Representative Marsh mentioned. If you look at that definition, it basically defines medication restraint and then says unless, and then it talks about essentially when the use of medication to restrain would be permitted. Now, that may seem, well, the reason that that's a problem is that medication restraint, as well as other restraint, is regulated and overseen by the Departments of Education, the Department of Health and Human Services, and my office, as well as the Attorney General's office, according to Chapter 126U. And it's overseen regardless of whether it is a legal use of restraint or a use of restraint that's not justified under the law. So if what you have on the books is a definition that basically incorporates the legal justification for it, it would relieve providers of the need to report and notify and basically cooperate with the oversight process if they could conclude that what we did was not actually medication restraint because it was justified. So under the current law, under 126U, all medication restraint is regulated. All of it must be subject to the notification and oversight requirements in the law, regardless of whether it is legally justified. So you could have two cases, one where the child definitely was acting in a way that required the use of restraint, or one where it was the use of restraint that did not actually meet the justification under the statute. Both of those incidents would need to be reported to the parents, and certain documentation would need to be prepared so that the oversight process could work. What this definition would do would allow a provider to conclude that because we think this was justified, we're not going to notify the parents, we're not going to keep the records that we would otherwise keep. And so I think it would really create a problem with the current statutory scheme. This is something that was previously the subject of discussion with the Office of Child Advocate. And I thought that at the time that we had those discussions, that they agreed that it would make sense to not incorporate the justification language. And it may have just either been a misunderstanding on my part about their position, or it may be that the committee in the House did not understand that that was to be amended. But in any event, I had a chance to speak to Representative Marsh about it and briefly to Rebecca Ross of DCYF. Rebecca and I have agreed to work together with the OCA, assuming that they are in agreement on an amendment to propose to you. I'm happy to answer any questions.
So, are there questions first? Okay. Here's what I would suggest before I close the hearing on this bill. Mr. Skibby, Ms. O'Neill, and I think if you were willing to work with Representative Marsh, which you both indicated you have, to make the amendment that adds at the end of section 4, the paragraph from the first page, and then clarify, delete, whatever the case may be, on what I believe are lines 27 through 30 on page 2 of the bill, and bring it back to the committee. I think that would be good. Everybody okay with that?
Yes, happy to do that, Mr. Chairman. And the definition is repeated several times, but it's essentially the same fix in each location.
Oh, well, you referred to it on line 27, so that's why I looked at it. Okay, very good. All right, so Griffin, do your last closure, and then we'll...
I don't have anybody else wishing to speak on House Bill 120. If there's anybody who wish to speak, please raise your hand or press star 9 if you're on the phone. I got nothing, Senator.
Okay. I will close the hearing on House Bill 120. We will await an amendment from Representative Marsh, working with Ms. O'Neill and Mr. Skibby, and we'll open the hearing on House Bill 220. And hopefully Representative Lang is with us. We're not that late at this point. And I know that there are some expert witnesses hoping to testify on this bill. I've sent that list to you, Kirsten. Hopefully it's gone to Griffin, because they should come after Representative Lang. Thanks.
I do not see Representative Lang in the attendees list, so I'm not sure if maybe a member of the committee wanted to introduce the bill for him, or if there's a House representative introducing us.
Representative
Cushman?
Blazek, Melissa Blazek, is she on the call?
I got Representative Cushman here, who I think is maybe going to introduce it for him.
Okay, very good. Representative, good morning.
Good morning. Thank you for having me introduce this bill. I wasn't expecting to, but I am on the Health and Human Services and Elderly Affairs Committee, and I am happy to do that for Representative Lang. Mr. Chair and members of the committee, my name is Leah Cushman. I'm state rep for Ware and Deering. As I said, I serve on the HHS EA committee for the House. This bill, HB 220, is a policy statement that in New Hampshire, people have a right to decide how to treat their own bodies and to decide what medical interventions to accept or decline without coercion and without compulsion. In the House Health and Human Services Committee, an amendment was crafted to ease concerns about the bill, and as amended, the bill received an 18-1 ought to pass recommendation, and it was placed on the consent calendar. The amendment carved out what some considered necessary caveats to the principles of the bill by explaining what it does not do. The bill does not supersede vaccination requirements for public school, because thankfully New Hampshire state law already delineates an exemption process for those. It does not prohibit employers from requiring vaccinations of employees when a direct threat exists. Under federal law, there are some conditions that need to be met. And when there's no ability for reasonable accommodation, that requirement can stay. It does not override the ability to involuntarily admit into medical treatment those who are experiencing psychiatric issues and are deemed a danger to themselves or others. It does not prevent the commissioner of DHHS and the courts from ordering treatment or quarantine for someone who has a communicable disease under RSA 141C. Thankfully, that statute already contains safeguards for due process for the rights of subjects to use alternative treatments, and it explicitly states that no person can be compelled to take any vaccinations. These statutes are referenced in the bill to head off unintended consequences and to clarify exactly what this applies to. As a member of the committee, I personally did not want to see these clarifying statutes referenced because I thought the bill as originally introduced said it all. As a registered nurse, I understand that the first provision of the American Nursing Association's Code of Ethics declares that patient self-determination is of utmost importance in medicine. We highly value it as nurses. Patients are unique individuals with their own biochemistry, medical history, values, culture, and knowledge, and they're to be treated as such. Therefore, they have the right to bodily autonomy and should not be subject to coercion. I believe this value of medical ethics should be applied to everyone and in all realms of society, not only within the field of medicine. What this bill does do is declare that in New Hampshire, bodily autonomy is important. It is a right that should be protected. It ensures that government shall not mandate any medical interventions. It says that we value self-determination and that medical decisions are personal and private. And it is a statement that echoes the intentions of the Nuremberg Code, the Belmont Report, and the Declaration of Helsinki, which all declare that humans have the right to be free from compulsion or coercion to accept medical interventions. I urge the members of the committee to give this bill an ought to pass recommendation to protect the bodily autonomy of the people of New Hampshire. Thank you, and I will take questions.
Thank you very much, Representative Cushman. Are there questions of Representative Cushman? Seeing none. I believe that Representative Lang, the prime sponsor of the bill, is now available and he's checking in. Good morning, Tim. How are you?
Great, Senator. Thank you. I apologize for being late to the meeting.
No, we were late. Not your fault.
Listening to Representative Cushman, Leah do a great job in introducing this bill. I don't have a lot to add. Again, this bill was modified to address concerns of the House Health and Human Services Committee. As a former police officer, I like the idea, I miss the idea of, dealing with involuntary emergency admissions and how this bill could potentially interfere with that kind of activity. And there were several others that were brought up from corrections, from DHHS relative to school vaccinations. And again, I think this is a good compromise bill that was worked out in the committee and amended in the committee. And I think it's a great first step in establishing this concept of inherent right to bodily integrity for all citizens in New Hampshire. And I don't really have a lot to add other than that. I think, again, as the bill's written, it's an excellent bill, a great first step bill, and that New Hampshire citizens are looking forward to this kind of economy. I can't tell you how many emails I got relative to this bill in favor of this bill about establishing in statute this freedom that we all already have and defining it in statute. And lastly, there was a great conversation around the application of this bill relative to private businesses. And as we saw that's where that last section 3 came in, talking about employers can only mandate if they meet the federal requirement of having that direct threat, job function interaction, that your job function has to have a direct threat that would necessitate a mandate, in which case the mandate could be imposed on a given private employer. But other than that, if you have any questions relative, I was involved in a lot of the discussions and I'm happy to take questions.
Okay, Senator Avard.
Thank you, Mr. Chair. Thank you for this bill as well. Representative, I'm just curious, would this apply to, say, a parent wants to go to a graduation like at, say, UNH or any other university? Can the campuses require parents in order to attend, mandate these vaccines?
My inclination would be to say no to that, no, they would not be able to allow that. And as I'll be that honest with you, I know probably what you're referencing because I have a son that's graduating from UNH this year. And I'm dealing with this issue directly as my, I understand. And my inclination of reading this would be that no, unless they can form some sort of direct threat, which we've already proven. Again, I serve in the governor's reopening task force. And we recently, the task force passed guidance for large outdoor venues to be able to host events. So they have guidance available to them to make a non-mandated, vaccination mandated event occur. And they're choosing a different path.
And one quick follow-up, if I may. Hold on, I just forgot it. It'll come to me if somebody else has another question.
Right. Are there other questions? I have one, Representative. Would you have any objection if we made this effective on passage?
I have no objection to that, Senator.
Okay.
Senator Avon.
Yes. So if somebody, what is the penalty if somebody violates this bill? So
well, that's a great question. It would be, I would imagine it's a civil penalty. We didn't initially put a penalty in here. And again, I'm not confident what the penalty would be. I assume the Attorney General's office could weigh in on that, what they would charge somebody with.
Thank you.
Senator Sherman.
Thank you, Mr. Chair. In the bill, and thank you, Representative, for joining us today. Let me just find it. In the lines 4 through 6, just wondering, how does this address minors?
Sorry, Senator, I have the amendment in front of me, which has the whole bill that was replaced by the House. If you could tell me what that section says specifically.
It's Roman 1. It says every person has the natural, essential, and inherent right to bodily integrity, free from any threat or compulsion that the person accepts any medical intervention, including immunization. No person may be compelled to receive an unwanted medical intervention, including immunization. So the question is, suppose a child has a curable cancer. The recommendation is that they undergo standard chemotherapy, which results in, say it's a lymphoma, it results in about a 70 to 80% cure. The family does not want this and wants to take the child somewhere else for an alternative therapy. And this isn't a gotcha question, but it has been settled by federal law and federal ethics that the state has a compelling obligation to protect the child. But the question would be, how does your bill impact a minor who needs potentially curative medical intervention when there's a conflict with the parent and the medical providers?
So again, I'm assuming, Senator, that again, this is an assumption because I'm not an attorney and I don't play one on TV either. But I would assume that the current process under the federal law would still hold sway over the state law, and that there must be a process if it's been settled in federal law under the ethics that, and I'm assuming that in that given case there must be some judicial intervention, and that judicial intervention would still apply.
Follow up?
Go ahead.
Would you be amenable to an amendment that would help clarify the impact of this bill on a minor patient?
I would not, again, as long as it respects your I don't want it to be an overriding, I guess. I'm a little concerned about encroaching into parental rights in the gray areas. In the example you give, it's very clear. Very, very concise, but no, I would not object to an amendment that clarifies that based on the federal law.
Okay, thanks.
Senator Whitley.
Thank you, Mr. Chair, and thank you for taking my question, Representative Lang. I'm curious whether the impetus for this bill, is this a problem in New Hampshire that we're seeing forced vaccinations, separate from school districts? Is this a problem in New Hampshire that we're seeking to solve with this bill?
Sure. So I will give you the answer to that question. The impetus of this bill was long before COVID. I serve on the House JALCAR committee, and I have for my last 3 terms, my third term on JALCAR. And what I saw happen in JALCAR I believe it was the end of the 2019 session, was Health and Human Services came in with a vaccination mandate for foster families. And there was no exemption requirement. In other words, that I could understand that if you had a child that was medically compromised in some way, you would want to make them go to a family that was vaccinated for whatever reason, if their immune system was compromised. However, this was a blanket rule that DHHS set, saying that if you want to be a foster family, you must be vaccinated. And not only you as the foster parents, but every child within that household must be vaccinated if you want to be a foster family. And when I asked the HHS about this, and I was especially more concerned about religious exemptions, again, people who, for whatever religious reasons, choose not to be vaccinated, would that apply here? And they said no. There was a blanket rule by the state that said that you must be vaccinated. And I felt that was horrific. That was impinging upon what could be perfectly great foster families and limiting our foster family pool based on the DHHS rule. And I thought that was horrific. And that was one of the impetuses of this bill, probably the primary impetus of this bill, was when I saw the state step into that mandate.
Just real quick.
Senator Avard.
Yes, thank you. Just to follow up again on the UNH mandate for parents in order for them to attend a graduation. I mean, that this bill becomes very, very important at this point.
Yes, it does. I think UNH would not be able to put a vaccination mandate again, because I don't think there's a direct threat. And we've given guidance for how outdoor large events could occur safely without a vaccination.
And one quick follow-up. Would you be amenable for a fine to be introduced if somebody violates the provisions of this law?
That would be fine with me, Senator.
That's it.
Are there further questions of Representative Lang? So, Representative, I just have one. I just want to clarify the question that Senator Sherman asked you about whether you, and hopefully by extension, if we did this, members of the House would be amenable to an amendment that made this for a person of the age of majority, which I believe would be anything 18 and above. You would accept that. Is that correct?
Well, I'd rather not limit it to 18 or above. What I'd rather do is, again, it's similar to Section 3, where we reference the particular employee mandate and the federal rule that applies relative to that. I would, as the Senator Sherman said, there is a federal guidance on this, and I'd rather reference that guidance for care in the extreme circumstances, because I don't want it to be a common circumstances that would impinge upon a parent's right to make a decision. I'd rather it be that narrow circumstances that Senator Sherman talked about that said there was federal guidance already on. And if we crafted that similar to Section 3, I'm sure I could sell that to the House.
Okay. Any further questions? Senator Sherman.
Sorry. Yeah, I just have a question. If you are a private commercial entity and you do not believe that it is safe, you own the business, you own the property, you do not believe it is safe for people who are not vaccinated to come onto your property, would your bill prevent a private commercial entity from saying you can only participate in the activities if you are vaccinated?
So again, if you read that federal statute 29 CFR 1630.2 letter R, that actually outlines exactly what is allowed. And that is decided, my understanding, that was decided in a Supreme Court case where a nurse who was a scheduling nurse brought action against the hospital who had mandated vaccines for all nurses, irrespective of job function. And in this particular case, the nurse had no job duty that was relative to patients. She was a scheduling nurse. She just was, she scheduled procedures and scheduled ORs, if I remember right. And the Supreme Court came down and said that there was no direct threat directly related to the job function, and because of that, they could not mandate. But I think that's clarified if you read 29 CFR 1632.
Follow up?
Senator Sherman?
Yeah, sorry, I probably didn't say it clearly enough. I'm not talking about employees. I'm talking about employers. I'm sorry, I'm talking about customers. So if you have a something that's going on in your business and you have customers coming in and you want to be sure you're protecting your employees and other customers because there is a vaccine available, and customers come in and say, I want to come in whether or not I'm vaccinated. It's my property, my business. Would I be able to restrict customers who I felt were a threat to my business because they're not vaccinated?
Senator, I'm probably going to leave that question because I honestly don't know the answer to it. Be dead honest with you, is that as I read this is about compelling medical intervention and compelling immunization. And so I think, again, customers, to a certain extent, customers have the right to choose, pick and choose where they shop. If Hannaford's has a mandatory vaccine requirement, if you want to come in and shop, and Shaw's doesn't, then I can just choose to go to Shaw's. So to a certain extent, I think that there is a case to be made that the potential individual business might be able to make a requirement. But I would hesitate to go down that road and say that that's a good idea. Again, because then you end up the haves and the have-nots and what you're allowed to do in society. And I think that's problematic.
Final follow-up?
Yep.
So to be clear, you don't know the answer to that, but you would be in favor of mandating that a private commercial business cannot restrict a customer based on their whether they've been vaccinated or not. So is this bill intended to restrict and regulate private commercial businesses and which customers can actually participate in that private commercial business? Are we telling commercial businesses what to do with this bill?
So that was not the intention of the bill. It was intended to apply to the state and state agents. It could be extrapolated out beyond that. I will tell you that, again, serving on the governor's task force and the latest set of guidances we're putting out, the last thing we're adding on the bottom of the task force is that any private business has the right to choose to have more restrictions rather than less than the guidance provides. Again, it's an individual private business choice. So that is kind of where I stand. That was not the intention of the bill, is to reach this out to private entities. That's why you'll see even the restrictions here are relative to mainly employment and relative to state agencies, again, Department of Corrections, law enforcement, those kind of things. So that was not the intention, but I could see where it could possibly be extrapolated out.
Okay, thank you.
Senator Whitley.
Thank you, Mr. Chair, and thank you, Representative Lang, for taking another question. So, and I'm going to lead up to this question here, but I need some setup. So, the choice to delay or reject a vaccine, it's not entirely a personal choice. And I understand that deeply because I have a 7-year-old who won't get a COVID vaccine for a long time. So, anyone who doesn't receive a vaccine is exposing my child to COVID. And, when we're talking about personal choices and personal decisions, this conversation that you had with Senator Sherman, I am concerned that with, as Representative Cushman indicated, this bill is strictly a policy statement. But my concern here is that this policy statement also might interfere with rights, prohibitions, whatever it may be under federal law. So would you be amenable to having the Attorney General weigh in on whether this policy statement is consistent or inconsistent with federal law?
Well, again, I always welcome the advice of the Attorney General. I guess it's Mr. Famella. I'm not sure if he's been signed. Attorney Famella has been sworn in or not. But yes, again, I'm not going to say no. I don't want you to listen to the Attorney General. And if there's a problem with the bill, then let's fix it. But again, I don't believe that this bill does violate in any way any kind of federal law and federal statute. At least that's it's been reviewed by several people, including an attorney. And so I again, yes, the Attorney General is welcome to come and weigh in.
Thank you.
Seeing no further questions. Thank you very much, Representative Lang.
And I just want to add again, this came out in 19-1 out of Health and Human Services Committee in the House. And not only that, it was on the consent calendar and was passed with no objection.
Thanks.
Right, so next up, I have Peter Mccullough.
Good evening, or good morning. This is Dr. Peter Mccullough. I'm a internist and cardiologist and epidemiologist at Texas A&M College of Medicine in Dallas, Texas. And I was asked to give just a few brief comments about this bill as it relates to COVID-19, and several of the senators had questions that were very specific to this. I'm considered an expert in the COVID-19 pandemic. I've published the 2 guidance papers on the early treatment of COVID-19 to reduce hospitalization and death, and I've testified before the U.S. Senate, Texas Senate, and Colorado General Assembly. My points with respect to COVID-19 is that it's a treatable illness early in high-risk patients. They should be treated early to reduce hospitalization and death. COVID recovered patients have no meaningful risk of getting a second infection nor transmitting the virus. So COVID recovered patients can neither receive nor transmit the virus to others. COVID recovered patients, pregnant women, women of childbearing potential, and frail seniors were all excluded from the COVID clinical trials program. So we have no data on safety and efficacy of those individuals. So any type of legislation that was coercive or pressured those individuals to receiving the COVID-19 vaccination would pressure individuals into an unknown situation where their personal safety is at risk. And in fact, with COVID-19, we've seen the first paper from Manchester, United Kingdom, demonstrating that COVID recovered patients, which were 26% of those vaccinated, had 2 to 3 times the increased safety risks, including hospitalization and severe reactions. The CDC currently recommends that patients who have vaccine reaction risks defer on having the vaccine. It's important to understand that now 2 important papers, one from CAO, and the other one from Madewell, published in Nature Proceedings and from JAMA, have demonstrated that asymptomatic spread is not a significant risk. In fact, it's minuscule, far below 1%. So an individual who's asymptomatic and who has not been vaccinated has no meaningful chance of transmitting the virus to someone else. So an asymptomatic person not vaccinated going into any workplace as a customer or employee, in my opinion, cannot be considered in any way an imminent threat. The final point is that any individual who did feel coerced or pressured into vaccination because of a federal or state policy or procedures by local businesses and organizations would have to contemplate safety data. And the current safety data reported into the vaccine adverse event reporting system held by the CDC up until April 2nd, 2021 Keep in mind, this is at about 60 million patients vaccinated. We have had 2342 deaths reported by people who have administered the vaccine and healthcare workers who have seen vaccinated patients die, 4972 hospitalizations, 8975 urgent care visits, 8744 office visits, 412 anaphylactic reactions, and 460 cases of Bell's palsy or paralysis of the face. In total, there's 56,869 events reported into this safety system. And to give you a reference point, in 1976, with the swine flu epidemic, there was an attempt to vaccinate the entire population. We got to approximately 55 million people vaccinated, and there were 25 deaths, and the program was terminated. With the annual flu vaccine each year, approximately 195 million people are vaccinated, and the number of reported deaths after vaccination are between 20 and 30. So at 2342 deaths, the majority have occurred with the Pfizer and Moderna vaccine. Physicians like myself are alarmed that the vaccine, in fact, could cause immediate harm to individuals. And in evidence of that, yesterday, the CDC and the FDA did put a pause on the Johnson & Johnson vaccine, which we previously thought to be the safest of vaccines. I still think it's the safest vaccine, and are currently having the Pfizer Moderna vaccine go forward. But these numbers are alarming. To make matters worse, there are vaccine failures that are pouring in at this point in time, and that the vaccine efficacy is nowhere near what we had thought. Data from Kusten in Denmark with 29,000 individuals in real world data suggests the vaccine failure rate is about 30%. So any business that would require patients to become vaccinated really could have this entire thing backfire, that a vaccinated patient would have a probability of contracting COVID-19 that could be modestly better than an individual unvaccinated. But neither one of those individuals, whether vaccinated or unvaccinated, should be considered differently by any business or organization at this point in time. And to be coerced, pressured, or face reprisal for declining a vaccine for any reason, and that could be a fear of a safety adverse event, for a religious reason, or for any thing that would fall along the American Disability Association, in my view, would be immoral, unethical, and illegal. Thank you.
Thank you very much, Doctor. Are there questions of Dr. Mccullough? Senator Sherman. You're also muted, Tom.
Thank you, Mr. Chair, and thank you, Dr. Mccullough. Welcome to New Hampshire. You said you are expert in COVID-19. Did you also say you're a cardiologist?
I'm a practicing internist and cardiologist, and a master's prepared epidemiologist. I have 600 publications in the peer-reviewed literature and 40 on COVID-19 over the last year. I'm considered in the field of COVID-19 to be one of the top experts in the country.
Okay. All right. It's interesting that you mentioned that, because one of my classmates from med school is one of the top experts in the country at Vanderbilt, and your testimony is different from what he has said to me separately. So given that, are you saying, because this would be unusual, are you saying that asymptomatic patients cannot transmit COVID even if they have COVID?
In detailed studies by both CAO from China and 9 million Chinese, and then by Madewell from 30, summarizing the reports of 39 other studies, asymptomatic transmission is far less than 1% of all transmission events. So the majority of individuals who actually have the virus, indeed have the virus proven, that in the cow study, for example, it's 300 patients, 190 of them were already forming antibodies. So they simply had a low level infection. But when the detailed analysis was done of all their contacts, they did not transmit the virus to the contacts. So this is very important. And in the cow study, the number of people under age 17 that were found to have the virus, and they sampled every single person in this 9 million study, only 4 individuals of the 300 were below 17, and none of them transmitted it to their parents.
Follow up?
Further?
Yeah, just a quick question. First of all, thank you. If you wouldn't mind providing the committee with those references, that'd be super helpful. And there was something you said about, wouldn't you agree that if they're already forming antibodies, they may be well along in their exposure, given the natural history of progression from antigen to antibody, and that they may well not at that point be contagious since they actually already have antibodies present?
Well, we would conclude that they simply haven't transmitted it because the case contact evaluation demonstrated that nobody in contact with them contracted the virus. And keep in mind, my opinions are certainly my own, and other doctors are entitled to their own opinions. All we can do is follow the evidence and the science, and it points to, at this point in time, that asymptomatic spread is far less than 1% of all spread. That means 99.9% of spread happens from a sick person to a well person.
Yeah, it's amazing how we can read the same articles and come out with different opinions. Thank you very much for your testimony.
My pleasure.
Thank you very much, Doctor. I think we will move now to Beth Daly. Good morning. How are you?
Good morning. Thank you. It looks like you can hear me okay. Thank you, Senator Bradley and members of the committee. My name is Beth Daly, Bureau Chief of the for Infectious Disease Control at the New Hampshire Department of Health and Human Services. I'm here today to provide testimony in opposition to House Bill 220. As you all know, immunization is considered one of the most important public health achievements of the last century. It's prevented millions of illnesses, disabilities, and deaths. However, despite these successes, vaccine coverage is not 100%, nor are these vaccines 100% effective. So infection can occur when an unvaccinated person becomes infected and then introduces that disease into a community. Therefore, we believe that it's critical that certain requirements for immunization remain in place to prevent the spread of these diseases in our communities and to protect our most vulnerable patients. We want to thank Representative Marsh for his work on this bill. He did work with the department to create some specific exemptions, and one of those exemptions was to ensure that the department retains its authority to require vaccinations prior to school and childcare entry. So we're pleased by this and appreciate Representative Marsh's work. However, we do still have some concerns about the bill from a public health perspective. If passed, this bill may impact the ability for certain employers to require vaccination. And this is due to the reference to 29 CFR 1630.2R, which states that employers may only mandate immunization as a condition of employment when a direct threat exists. And this language suggests that employers are making this determination for themselves, which could lead to inconsistent application of the law throughout the state. And it also opens the door for future restrictions on immunization requirements and likely has other unintended consequences as well. So we are concerned about the bill still, even though there were some modifications made to it. And in particular, again, we're primarily concerned about the impact of the bill on employee vaccination in healthcare facilities specifically. Many of our healthcare facilities do require employee vaccination to protect the lives of their most vulnerable patients. For example, all hospitals in our state have policies requiring influenza vaccination. Now, many do allow for certain exemptions, such as for medical or religious reasons, and then some only allow for medical exemptions. these policies have increased our vaccination rates in healthcare workers from less than 60% to almost 95% for imminent influenza vaccination. Now, in our long-term care facilities, fewer of these organizations have policies requiring influenza vaccine. And each year in New Hampshire, we have about 25 to 50 influenza outbreaks in long-term care facilities, affecting hundreds of residents and resulting in preventable hospitalizations and deaths. So our goal around immunization policy is to provide that public health protection, but also appropriately balancing individual choice. And we believe that under existing law, people already have a choice of whether to be vaccinated. They don't have to be vaccinated, only if they want to participate in certain activities where their decision not to be vaccinated will put others who are vulnerable at risk. So healthcare workers can choose not to put their patients at risk by either getting vaccinated, or if they don't want to be vaccinated, not to work in these settings. And if we eliminate these employee vaccination policies, we do expect that our vaccination rates will decrease and that our preventable disability and death will increase. And that's potentially going to result in harm, especially to our vulnerable medically fragile patients in hospitals and long-term care facilities. Thank you for the opportunity to testify, and I'm happy to address any questions you have.
Senator Whitley.
Thank you, Mr. Chair, and thank you for taking my question. So it sounds like, correct me if I'm wrong, but it sounds like under existing law, we do a pretty good job balancing the difference between personal freedoms and, obligations to our community and protecting public health. So are you concerned that this bill, this policy statement, trying to solve a problem that doesn't exist, will sort of upset that delicate balance we already have in New Hampshire?
We do believe that there is already a balance and that there's potentially harmful impacts from this legislation. Yes.
Thank you.
Senator Avard.
Thank you, Mr. Chair. Just two questions, if I may. Requiring vaccines by employers would basically give the employer the right to put my personal health at risk if I chose not to, right? I mean, if I believe that there were potential health risks, as the previous testimony just pointed out that there are some, I'm giving the employer the right to either jeopardize my health or my personal income. Is that what you're saying?
Yeah, thank you, Senator Avard. So what we're talking about is balancing different perspectives here, right? So if you are a medically vulnerable patient, perhaps you can't get vaccinated or you're otherwise medically vulnerable, you're going to be at increased risk for death if you acquire one of these infections. And so healthcare workers have an obligation to protect their patients. And certainly we don't want them to infect their patients and cause harm to them as well. So I think there's a special obligation for certain employees to take that step to do what's right to protect their patients or not to work in the field. First, do no harm, right?
Right, but putting my health at personal risk in the balance of things is the question I'm trying to get at. What are the potential health risks for taking the vaccine? Is there, I mean, if you watch television on any level and you see a prescription drug being put out there, you got some beautiful music, some beautiful background, and then all the health risks are being promoted, whether it's an aspirin or whatever it is, may cause this, may cause that, may cause this. But we're not seeing that with these vaccines. And so if somebody's being forced to either have a job that they've been all their life or take the vaccine, you have to choose. Are there going to be warnings saying, look, if you do take this vaccine, these are the potential health risks? Our health is in the balance and we should have the right to choose, it would seem to me. But if I thought, well, maybe this might be a problem with my health, shouldn't I have that choice and not have to worry about losing my job?
So thank you, Senator Avard. The vaccines that are in use today are very safe and effective. You heard a lot of misinformation that was just provided to you. There is tracking for these potential side effects from vaccines, and they are clearly spelled out to individuals who get the vaccine. Most people experience pain, swelling, redness At the injection site, you can have some fatigue, headache, those types of symptoms. It obviously varies on the type of vaccine that you're receiving. So it's different by a vaccine formulation. I'm talking generally about vaccines in general. I'm not aware of any person who's died from receiving a vaccine in our state in my 17 years at the department.
And a final follow-up, if I may, Mr. Chair, and I won't ask any more, but over the long term, do you know if these vaccines will cause any birth defects? I mean, has there been enough studies to indicate what are the long-term effects of these vaccines?
I don't know if you're speaking specifically to COVID vaccine,
Yes.
but no, so COVID vaccine, the recommendation from the American College of Obstetrics is for pregnant women to get vaccinated. They're at increased risk for having severe complications and dying from COVID-19, and they should absolutely get vaccinated.
Wow. Thank you.
Senator Sherman.
Thank you. Hi, Beth. Great to hear from you. And I want to, first of all, give a huge kudos to the department for I think we almost lead the country in our vaccination rate for our senior residents in our senior residential facilities. And recognizing that is where the highest percentage of mortality in New Hampshire has been from COVID. What would be the impact if we were not to require vaccination, or to not at least encourage vaccination among the people working in those senior residential facilities who go home and come back, to people who are basically housed in nursing homes and assisted living facilities? The department has done a really good job of working with those employees and making sure that as many of them are vaccinated as quickly as possible. But knowing the impact of COVID in that setting or in the hospital setting, what would be the impact if we just left it up to the employee in terms of mortality in the in those facilities?
Thank you, Senator Sherman. Are you speaking to COVID-19 or other like influenza vaccine?
No, well, we see the flu race through our nursing homes every year. And I think the great news is, with all the social distancing and masking and everything else, it's been remarkable what an incredible drop we've seen in the flu, that combined with the vaccine. But really asking about COVID-19, the vaccine, I think to the other senators, to Senator Avar's concerns, there is a patient information sheet that's given to everybody who wants one for the vaccine. But in terms of the impact on our most vulnerable, which is what we're talking about here, for someone to go into a nursing home unvaccinated when a vaccine is available, what would be the impact on that potential nursing home? How many people would be impacted?
So our experience with COVID-19, as you know, is that once COVID-19 is introduced into one of these facilities, it spreads very rapidly, has very high attack rates, and certainly we want to keep COVID-19 out of those facilities. We know that the way that it's being introduced is through the staff, because right now, with at least during the height of the pandemic, there was no visitation allowed, and it was tightly controlled who was coming in. And you could trace some of these outbreaks to staff members testing positive first. So we want the staff to be protected. Right now, there's no requirement that they get COVID-19 vaccine. About 75% of the staff in those long-term care facilities have chosen to be vaccinated, which is great, certainly in the best interest of their residents. We do still have a few outbreaks of COVID-19 occurring in facilities because the vaccine is not 100% effective, nor did 100% of people, take the vaccine. So there's still opportunity for it to occur. And like I said, we do have lots of flu on a normal influenza season, not during COVID, circulating, and we have people dying in long-term care facilities from influenza that was likely introduced from their staff who are not vaccinated.
Follow up?
Yeah.
And just one quick follow-up. At my facility where I work, which is a hospital, if you choose not to get vaccinated during the flu season, you have to wear a mask around patients to protect the patients. But there is that option to opt out of the vaccination program. And so my question would be, don't we already have protections for people who don't want to be vaccinated, even in some of our most sensitive workplaces?
Yes, that is a common policy in healthcare organizations. If they do require vaccination of their healthcare employees, then if one person chooses not to be vaccinated, then they would have to wear a mask during high peak influenza season.
Thank you.
Further questions of Ms. Daly? So I have one. Ms. Daly, do you have a definition of a healthcare worker in statute that you could provide for us if we want to consider a carve out for essential healthcare workers?
There is a definition from CDC that we often use for healthcare personnel. It's quite broad because it addresses all people who are working in the healthcare setting, including environmental services, food service staff, and those who have that direct patient care. So we have that definition that is very commonly used, and the recommendation is for all of those individuals to get vaccinated because the transmission can occur from those who don't have direct contact with the patient necessarily to their coworkers and then to the patients.
Okay, if you could get that to us, that would be helpful.
Yes.
Senator Whitley?
Yeah, I would, Senator Bradley, I would just point out too, there is a definition for healthcare provider in RSA 141C, which this bill seeks to amend.
Okay. Great. Thank you very much, Ms. Daly. I want to echo Senator Sherman's regard for the work that you've done throughout the entire pandemic.
Thank you very much.
Okay, Griffin.
Next person I have signed up to speak is Deanna Pollard Sax.
And Senator Avard, can you take over for just a moment?
Welcome, Deanna.
Hi, yeah, my name's Deanna Pollard Sax, and thank you for hearing me today. I just want to explain my background is in liberty jurisprudence. I have a pretty significant background in teaching and writing scholarship about constitutional law, so this is right up my alley. In addition, I just wrote an article about the vaccinations and what's going on with the courts and how they basically misapplied Jacobson versus Massachusetts for 116 years. And that article will come out in the Florida State University Law Review in the spring as the lead article. And by the way, the United States Supreme Court has made 2 rulings since my article went online last summer. And you can get it online right now on ssrn.com or ResearchGate. And both those Supreme Court decisions were consistent with what I was arguing in my article. So we already have some signs that there is going to be a major shift in how medical liberty is viewed by the courts. But the first thing I want to do is just address something that came up while I was listening to your hearing, and that is the question about whether this could be challenged in some way, this law. And I read the law, the House Bill 220. I did not read all of the RSAs, but I will tell you one issue I saw off the bat was the United States Supreme Court has made a number of decisions about when a state can order treatment of a child over the parent's wishes, because sometimes parents raise religious reasons not to give a blood transfusion or something like that to a child who would die without it. So when it says no person may be compelled to receive an unwanted medical intervention, including immunization, I'm going to talk about the unwanted medical intervention. That particular clause could conflict with U.S. Supreme Court precedent, balancing the right to reject medical treatment against the state's interest in preserving the life of a child, the life or serious, the life or something like that, a very serious health condition. So there is that, just to put that out there. Now, I didn't read all the RSAs, so it may be that one of these RSAs discuss that and say that this is an exception. I'm not sure. But there is a state interest for a minor. For those of us in the majority, over age 18, there's a very clear rule that no medical treatment may ever be mandated. That comes from a case from 1990, called Cruzen versus Missouri Department of Health, and that's known as the right to die case. We have a right to die, an unfettered right to say, no, let me die, and they have to let you die if you choose that. Several years later, there was another case seeking a right to assisted suicide, and the court said, okay, you don't have that. So you don't get to take life-terminating medication, but you can reject life-saving medication. So that's clear, and this law is completely consistent with that in terms of adults. The only issue I see potentially is for a child where the parents or the parents normally give substituted consent for the child because the child's a minor, but sometimes the child is 16 or 17. But even then, the state can step in and say, you're too young to make this decision. It could kill you. And there are times when the courts will order treatment over the state's decision on that. So having said that, in general, I do support this bill. Medical liberty lies at the heart of the Liberty Clause. No aspect of liberty throughout constitutional jurisprudence has ever been protected stronger than medical liberty. And for a variety of reasons, vaccinations are this glaring, enormous exception to the rest of constitutional jurisprudence when it comes to medical liberty. So there's a problem there. And that's what my article is about that I just wrote and will be published soon, about the imbalance that has occurred between the legislatures and the courts, with the courts basically just stepping out of the game and not even entering the field, just are completely gone, misapplying the law. Even when they say they're applying strict scrutiny, they don't apply the test. They forget about two of the prongs. It's absolutely, it's kind of embarrassing reading these cases. And I went through every single lower court case in 116 years and explained why they all got it wrong. And so again, the US Supreme Court seems to be leaning, or they've made two decisions that indicate they're not going to follow Jacobson, not when a fundamental right is involved, whether or not there's a pandemic. That's specifically what the court has said. It doesn't matter. This is when we need our rights protected the most, when there's an urgent situation. So the Supreme Court has indicated to lower courts, you must look at these laws, you must review them, and you must do your job as a court to protect individual liberty from state action. That is the role of this branch of government, the courts, and they've been asleep at the wheel for a very long time. So I'm in favor of this bill. I also I'm not, the concern, I guess, that people have is those working in the medical industry. And I'm not quite sure how that will pan out. I can tell you when it's a state, like a UCLA, it's going to come down to straight up constitutional law because it's a state action issue. But when it's a private hospital, the issue is a little different. So that's where this possibly could come in to protect workers in those private hospitals in a way that they wouldn't have otherwise, because private entities are not bound by the Constitution. You can't assert a right of liberty against Nordstrom or Walmart, but of course you can against any branch of government. And so I guess that's basically what I want to clarify is there could be a problem insofar as the law or these subsections quoted in this law do not address the issue of when a minor will die without medical treatment and the state can step in and mandate it. So it says no person may be compelled. Well, a minor can be compelled. So just to clarify that and make sure that that's somehow incorporated into the law. Otherwise, it probably will be challenged eventually by whatever state department you have that seeks court orders for medical treatment in the event that the parents don't want it and the minor child doesn't want it. So I can answer any questions you have about vaccinations or the constitutional law that govern these issues. But I will say that I see no chance, zero chance, that a state will ever meet its burden under strict scrutiny, which is what I'm arguing in the Florida State University Law Review is the only standard that makes sense based on the history of constitutional jurisprudence. They must apply strict scrutiny, in my opinion, because that's what's applied in so many other areas, even the right to abortion, which isn't it isn't unwanted medical care, it's wanted medical care. It's a different issue. Even that gets strict scrutiny. The state can't dig out a bullet from someone's arm to prove that was the person who shot the gun or was shot at for forensic evidence in a criminal case. Can't do it. The state can't force pump someone's stomach to obtain evidence that he ingested the heroin as the police were coming into his room. Can't do it. The only thing the state has been allowed to do in terms of compelled medical procedures in the criminal cases is a blood test or a urine test to prove drunkenness and that sort of thing. And that's just because there's just no risks involved, or the risks are so minimal, I should say. With urine analysis, there's really no risk. With a blood test, you're drawing blood. It's tiny risks that are almost, so minuscule compared to the evidence that's obtained. But again, when there's more risks involved, the U.S. Supreme Court has pretty consistently said you can't do it. You can't put people at risk, even when you need evidence for a criminal case. And so when you look at the vaccine jurisprudence, it's just really different. They have a whole different analysis. They're exposing children to possible death and illness. And I know that there's an exception here for the school vaccination requirement. In my opinion, that also is going to be reviewed, and that also is going to be under attack in years to come. In terms of adults, of course, it's a little different. But for example, the New York law requiring babies and all persons and all the way up to the assisted care facilities to have flu vaccines every year, that law, in my opinion, will be struck down. I see no way they can defend that. The same with the Hawaii law requiring the HPV vaccine for girls to go to school. I see no chance that will be that will withstand constitutional scrutiny because of the data on the flu vaccine efficacy and the data on the HPV risks and efficacy. Once you get a court to review these cases, these laws properly, the state is going to have the burden to prove that these vaccines are doing what they say they do and the risks aren't too big. And for at least some of them, HPV and the flu vaccine, the risks are too high, in my opinion, if you look carefully at the data. And now to go into how many legislators have stock in the companies that make these vaccines, the whole other issue, and that's addressed in an article that I also have online called "The Vaccine Controversy and Constitutional Limits to Coerced Vaccination." That one is going to be published in a smaller version, like I mentioned earlier, called Judicial Protection of Medical Liberty. So I'm here to answer any questions you have, but I do support this bill. I'm a huge supporter of individual liberty, especially medical liberty. We all are different. No one knows your body better than yourself. My doctor will say that. He doesn't know my body the way I do. I mean, he's a doctor and he can help me, but if anyone's going to make a decision about what I do, I think it should be me. I've been living inside this body for, 57 years. So I'm a big supporter of the right to medical autonomy, and I'm here to answer any questions you might have.
All right, so Attorney Pollard Sax, I'm going to ask you to stay on the line because our next witness has an 11:30 commitment. So Griffin, if you could recognize our next speaker.
Good morning, members of the committee. My name is Dr. Christine Arsenault. I am a pediatrician and the vice president of the New Hampshire Pediatric Society, the state chapter of the American Academy of Pediatrics. My testimony is on behalf of that organization. Thank you for hearing my testimony today. I am here to provide testimony in opposition to House Bill 220. There are several concerning aspects of this bill, including the restrictions that it places on business owners and members of law enforcement. As a mother and a pediatrician, however, I'm most worried about the effect on vulnerable children in our community. This bill puts an individual's right to refuse medical therapy above the health of our community as a whole. I would like to echo Beth Daly's gratitude for Representative Marsh's work to continue to allow the DHHS to supervise immunization regulations in public schools. However, we, the New Hampshire chapter of the AAP, continue to oppose this bill out of concern for the effect on vulnerable people in our community. I think many of my points have already been raised. So Representative Sherman raised several excellent points. As he alluded to, there are 4 principles of medical ethics, which are autonomy, beneficence, malfeasance, and justice. Autonomy is extremely important to an individual's health. However, it should not be a principle that is preserved at the expense of another person's well-being. There are many principles in place in our state already for individuals to have medical autonomy. And this bill really seems unnecessary, and the vagueness of the wording is a little bit dangerous in our opinion, and perhaps would threaten the health of vulnerable people at the expense of the autonomy of some. Further, it is well established that we as medical providers should act in the best interest of a minor child if a threat is imminent, even if the child's parent disagrees. For example, if a child needs a blood transfusion to survive, but the child's parents do not want that intervention, we as medical providers are legally bound to give the life-saving intervention. I know this has been mentioned a couple of times, and Representative Lang said that he assumed that minors would be exempt from the bill's wording, but that vagueness is worrisome and potentially dangerous. The other issue that has been brought up already is the effect that this bill may have on small businesses and their right to choose who their customers are and whether those customers are vaccinated. Also, in hospitals requiring influenza vaccination, as Beth Daly said, to ensure the health of the patients coming in and out, some of whom are receiving chemotherapy and are unable to make the choice for themselves to get vaccinated. This is not a field that the government should prevent from companies and businesses from being allowed to do. I think that, as Senator Woodley also pointed out, an individual's right to refuse vaccination affects more than just that individual. I think you're all familiar with the concept of herd immunity and how, if a larger percentage of the population is immunized, that will protect those who are unable to be immunized, either because they are immunocompromised or are infants who are very vulnerable to these vaccine preventable illnesses. I think sometimes we forget how devastating these illnesses can be because we've had vaccines for so long. A colleague of mine had a preschool aged patient pass away this year from chickenpox because this child was unable to be immunized because he was receiving chemotherapy. These are the kind of things that we will see if, restrictions are placed on some of the public health efforts that we have made in the state. I think the example that Representative Lang used of a foster family being required to get recommended vaccinations is a good example of why this bill is dangerous as well. If the government is entrusted to care for a child because his parents are unable to do so, we must do the best we can to protect that child using the best medical evidence available. And foster families are required to meet a whole host of regulations in order to keep children safe, and this should not be any different. So for these reasons, and also just for the fact that this bill is not necessary to ensure medical freedom, there are medical exemptions for vaccinations, religious exemptions for vaccinations, many principles in place to assure autonomy for individuals in our state. We at the New Hampshire Pediatric Society recommend that you oppose House Bill 220. Thank you very much for your time.
Senator Whitley, I'm going to restrict it to one question per because we have 16 more speakers. Senator Whitley.
Thank you, Mr. Chair, and thank you, Dr. Arsenault, for hanging on with us. We appreciate and respect your time. So isn't it true that vaccinations are held to incredibly high regulatory standards, and they're extensively tested for safety, efficacy, not only before they go on the market, but once they are on the market? Isn't that the case?
This is absolutely the case. All of the vaccines that have been recommended and are on the CDC's routine immunization schedule, which is what we follow here in the state of New Hampshire, are very well studied, have been studied for decades, if not, they have been studied for decades, I will say. And I think that anytime we look at any decision we're making, we weigh the risks and the benefits, and there are rare risks with vaccines. However, what people forget because we don't see them is that children die from pertussis and children die from chickenpox and elderly people die from these diseases. And so we look at the risk of maybe, 1 in 100,000 of, having a neurological complication from the flu shot. And we are so fearful of that when the risk of having developing a staph pneumonia in a healthy child following influenza is far greater. And, I think that we as humans have a bias to be fearful of doing things. It feels safer to do nothing. But if you look at the risks and the benefits, which the CDC does, our Department of Health does, these are extensively evaluated, extensively studied, and it is much safer to get these immunizations than to not.
Thank you.
Seeing no further questions, I will just say, Doctor, that all of these vaccines are on an emergency use FDA approval and have not been studied for decades. So there's a very real difference that
I think maybe you're referring to the COVID-19 specifically. I'm actually talking much more about the routine childhood immunizations that are recommended by the CDC, all of which have been studied for decades.
And none of which, as I understand it, would be affected by this legislation.
So the legislation does not specifically exempt children from any of the, in the wording. I know that there has been sort of discussion throughout this testimony that we assume children would be exempt. That's not stated here. I also think that the COVID vaccine has not been studied for decades, but it has been studied in many, many people. And I think we've all observed that when there is any sort of negative side effect, even if it's extremely mild, such as with the Johnson & Johnson vaccine, or I should say extremely rare, those vaccines are immediately pulled. So we are constantly, as healthcare providers, looking at the risks and the benefits of vaccines. And the second we have an inkling of a worry that the risks may be approaching the benefits, we stop and we take a step back. So I guess that's all I have to say about that.
Very good. Thank you very much, Doctor.
Yeah, thank you.
Okay, Griffin.
Next person I have signed up is Tom Renz, but I do not see him in the oh, there he is. Tom, you have to unmute on your end. And I think he just dropped off the call. All right, so moving along, I got Erica Lehman, I think it is. Leon, sorry.
Thank you very much. Thank you, Chairman Bradley, and thank you, Senators, for hearing my testimony. For the record, I am State Representative Erica Leon, representing Derry. Before serving in the House, I was a medical device analyst on Wall Street. In that role, I attended many FDA hearings, evaluated clinical study programs intended to support approval and market acceptance, and I focused on several treatment areas. My experience with cardiac stents, among other interventions, as well as my due diligence on the vaccine industry from the Wall Street perspective, inform my testimony today. As you know, medical ethics are built on the idea of first do no harm. At many American Heart Association meetings, leading cardiologists advocated putting statins in the public water supply because they thought that this would save lives. This was before studies showed that there was actually no impact on plaque formation, and there were serious safety risks that have come to light. I also worked with a cardiac pathologist who determined why heart patients with drug-eluting stents began dying from blood clots long after their stents were placed. Both of these therapies were considered to be incredibly low risk, but real-world data showed that there were real and lethal threats. These risks did not come to light until they were widely available, and treatment has changed based on these risks. This is relevant to vaccines. I had the opportunity as an analyst to attend a vaccine conference at MIT that looked at lessons learned from SARS and MERS and looked at how to bring to market a vaccine for the next pandemic, the situation we find ourselves in today. The strategies suggested and employed in the years that followed included pursuing only emergency use authorization in order to bring a vaccine to market quickly. There was no support shortening the approval process for any other vaccines, just in the case of a pandemic. It's critical to understand that there are no vaccines approved for COVID-19. They have not undergone the same kind of testing required for other vaccines. The studies of the vaccines available under emergency use authorization were designed for authorization. They did not pursue rigorous scientific inquiry. Further, they allowed for crossover once the vaccines were available. This means the control group, those who did not get the vaccines, were allowed to get the vaccine as soon as they were otherwise eligible. This means that any long-term data, both safety and efficacy, does not reflect the quality of evidence that supported the EUA. This extends to the durability of response, so we don't know how long these vaccines will even help. Caution over new interventions is not pathologic. This caution is supported by long-standing experience. We have data that shows that these vaccines probably help in COVID. There's definitely a good signal, and that's why we have emergency use authorization. Something is better than nothing, but something doesn't mean that there are not risks that a conscientious person could not see. Right now, we need to look at that balance of medical treatment, look at the standard of evidence, look at the quality of data, and recognize that people may choose not to get this vaccine or another one, and that is a logical choice. Encouraging medical treatment or vaccination is one thing, but compelling a medical intervention should be unacceptable. So I encourage your support of HB 220.
Senator Sherman, one question.
Thank you, Mr. Chair, and thank you, Representative. I would assume that you meant rather than logical, it's a personal choice. But the question I have is, where in statute right now is anyone compelled to get a COVID vaccine as you're describing? I thought adults do have a right to refuse the vaccine. And specifically, where do you think, I guess that's my question. I just don't know where in statute right now an adult could not refuse to get the vaccine. I know many who have.
Thank you for your question. Right now, this is a clarifying issue that is emerging. We've seen what happened. I think Representative Lang spoke to this point very clearly. I'm not a sponsor on this bill. We are trying to make sure that people are not placed in a decision where they have to choose between their livelihood or potential health risks. It is inappropriate to ask for people's contraindications or other reasons why they would refuse a treatment. If a woman is pregnant and is concerned about the effect on that child, I understand that it's recommended by ACOG that pregnant women get this vaccine. However, they were not studied. If a pregnant woman believes that the risk is too high, yet she doesn't want to disclose to her employer that she is pregnant because she's still early in her pregnancy, that would put her in a very difficult position. Right now, this is to clarify what is going on and to make sure that nobody can be forced to do this.
A quick follow-up. Sorry, I know you said one. I know, but just quick follow-up. Where currently, I mean, if we're trying to clarify this, maybe we can clarify it without legislation. Where currently is a woman, pregnant or not, required to be vaccinated for a purpose of employment in New Hampshire?
I didn't say that she would, thank you for your question. I did not say that a woman would be required to be vaccinated. If we are talking about medical exemptions and sharing why somebody does not get an intervention, that could disclose private medical information, and that is a concern.
Not what I asked, but okay, thank you.
You can do that research yourself, Senator Sherman. Seeing no further questions of Representative Leon, Griffin, go ahead.
Yep, next person I have signed up wishing to speak is, let's go.
I think it's
Yeah,
Dr. J. Butchara.
I'm just going to say Dr. J.
Dr. J, yes, you've got him.
Great. Can you all hear me okay?
Good morning, sir.
Good morning. So thank you for letting me speak. So I am a professor of medicine at Stanford University. I've had 20 years of experience in publishing on infectious disease epidemiology policy, going back to HIV days. I've published on H1N1, antibiotic resistance. I've worked for the last decade on vaccine safety with the FDA, doing research on vaccine safety and advising the FDA on that. In the COVID-19 era, I've worked on, I published the very first seroprevalence studies in Los Angeles County. I've done evaluations of the lockdown efficacy of contact tracing, all published. I'm the co-author of the Great Barrington Declaration, one of the an argument for a very different kind of policy than we have been following for COVID-19. I'm going to speak only about COVID-19 vaccine. I'm not going to talk about any of the other vaccines. I think that vaccines are one of the most sort of the greatest invention in science. It's been an enormous boon generally to public health, and I think the COVID-19 vaccine also is an enormous boon to public health. And so I'm going to speak in favor of the COVID-19 vaccine, but against COVID-19 vaccine passports, because I think passports and mandates for this particular vaccine undermine public health. So first, a few facts. One, the disease risk for COVID-19 is enormously asymmetrical. Older people face 1,000 times more risk from disease than do younger people. A comprehensive analysis of the seroprevalence studies that have been done around the world find that if you are over the age of 70, there's a 5% mortality risk from COVID infection if you should get infected. If you're under the age of 70, there's a 0.05%. In other words, a 99.95% survival rate from COVID if you're under the age of 70. And this is published in the Bulletin of the World Health Organization. Second, let me agree with Dr. Mccullough, who testified earlier about asymptomatic spread. The evidence now very strongly indicates, including in publications in the Journal of the Medical Association and elsewhere, that there's very low risk of asymptomatic spread. Let me just describe very briefly the evidence. There's a study in the Journal of the Medical Association that covers that there's a meta-analysis of 54 other studies, but it found that inside households, someone who's asymptomatic or pre-symptomatic, the other household members get infected only 7 out of 1,000 times. Whereas if you're symptomatic, it's more on the order of 180 out of 1,000 times, 18% versus 0.7%. Asymptomatic spread is much more rare than I think many public health authorities let on, given what the scientific evidence now says. Third, let me talk about vaccine effectiveness. I think the vaccine is incredibly effective. The COVID vaccines are incredibly effective, so upward of 90+%. The key thing to realize is that even when it's deemed ineffective because someone can get infected with COVID after they get the vaccine, and in fact, it's still effective because it's much less likely to have severe outcomes from COVID should you have the vaccine. The vaccine is protective even if you get COVID. You're much less likely to die from it or to be hospitalized from it if you get the vaccine. So I think the COVID vaccine, the evidence is really clear. It's quite effective. And in particular in reducing the severity of disease. And that's, I think, true for all of the vaccines that I've seen. They're also protective against the variants as well. This vaccine is a godsend. It's absolutely imperative that we message correctly so that people want to get this vaccine. Now, on vaccine passports, I believe vaccine passports are a terrible idea. Vaccine mandates are a terrible idea from a public health perspective. There's already a lot of vaccine hesitancy in the population at large, created in large part by public health messaging, poor public health messaging around this vaccine. So for instance, you've heard Dr. Fauci say that if you get the vaccine, you shouldn't live a normal life. That's created vaccine hesitancy. If you start mandating this vaccine, you already have a lot of people that are skeptical about public health because of the poor performance of public health throughout this epidemic. I think if you mandate the vaccine, or if you require the vaccine passports to lead a normal life, as in a sense, what you're doing is you're creating a two-tier society. One group of people that are allowed to participate in normal life, another group that's not. It's effectively a vaccine Jim Crow that you will permit if you allow there to be these sorts of mandates permitted in society. And it'll create vaccine hesitancy. It'll say, people will start to say to themselves, why, if this vaccine is so good, do I need to be forced to take it? This is poor public health policy to mandate this vaccine when in fact it's not necessary. Instead, what we should do is we should tell people the good news that this vaccine is great. We should of course be clear about what the risks are for the vaccine, as we see with the Johnson & Johnson thing. 6 out of 7 million people got this blood clot issue. We should be clear that there is a risk, and then we should also tell them what the risk of COVID is. For the older population, the vaccine risk is so much smaller than the risk of COVID. It is enormously important that the older population get vaccinated. And in New Hampshire, I think somewhere over 80% of the older population already has had the first shot, at least from one of the vaccines, which is fantastic news. What you're going to see is that population is at much lower risk now than they were from COVID. We should not create vaccine hesitancy by mandating the vaccine. The vaccine passports and mandates are a solution in search of a problem in the context of COVID-19. Thank you for your time.
Senator Whitley.
Thank you, Mr. Chair, and thank you for your testimony. You see me sort of squinching my eyes and looking questioningly, because your testimony was about vaccine passports and a vaccine mandate. But you understand that this bill doesn't create either a mandate nor a passport, correct?
My understanding is that the bill prevents those sorts of policies from being adopted.
That's not how I'm reading it. We had.
I mean, you guys are the legal experts. I'm testifying on the medical and the public health aspects of it.
Okay, thank you.
Senator Avard.
Thank you, Mr. Chair, and thank you, Dr. J, for actually coming to testify. You said earlier in your testimony that you agreed with the previous testifier. Was it Dr. Mccullough?
Yeah, about asymptomatic spread.
Correct, and I thought that was rather interesting. But then the following testimony from Beth from the Department of Health and Human Services said that his testimony had a lot of misleading information in it. And I'm curious, did you find anything misleading in his testimony?
I mean, I can't speak. I didn't hear the entire of his testimony. I did hear his testimony on asymptomatic spread, and he's absolutely right. If she was referring to that testimony, then she is arguing against what the medical literature is saying.
Thank you for your testimony.
Okay, seeing no further questions of Dr. J, thank you very much.
Thank you.
I will call Thomas Renz.
Can you hear me?
Yep.
Yes.
Wonderful.
Good
Wonderful.
morning,
We had
sir.
troubles on the last one. Thank you all for having me. I'm working on litigation related to this around the country. I'm not licensed to practice in New Hampshire, so I'm going to talk about this from a high-level perspective, what I'm seeing. The previous attorney that testified, I loved some of what she said, and I'd actually further what she said a little bit by pointing out that in terms of individual liberties, one of the things that we've seen is since Roe v. Wade particularly, there's been kind of a really clear mandate from the Supreme Court and elsewhere that individual liberties in terms of bodily integrity trump pretty much anything else. And in fact, in Planned Parenthood v. Casey, they actually cite Jacobson and say that a state's interest in the protection of life falls short of justifying any plenary override of individual liberty claims. I take that to mean that I agree with the previous attorney, you really cannot mandate a vaccine, particularly an adult. With regards to children, I think I agree also that it's a little less clear, but I would point out this. It's interesting that I hear people talking about kids and kids and kids. Well, let me tell you what,
There's been 379 deaths nationally for children under 18 from COVID. And that's with COVID, using the misleading data structure used by the CDC to characterize this, because they've combined codes 701 and 702 into one code. So probable and possible cases are all combined into one thing. And that's very, very clear in the rule that did that. When the CDC issued the rule for death counting related to COVID-19, I want to read a quote from that rule. The rules for coding and selection of underlying cause of death are expected to result in COVID-19 being the underlying cause more often than not. That's from the CDC, so we're not misleading anybody. That's just what it says. With that, 379, we've had a lot more suicides that are likely the result of the lockdowns and the stuff that's occurred with this. This bill prevents discrimination. If we go back to the 80s, there was a young man named Ryan White. His story was very moving, and a few of you might be old enough to remember him. In the early 80s, we had the AIDS epidemic broke out, and people were discriminating right and left against people with AIDS. AIDS was killing people. AIDS was almost 100% fatality rate back in those days. COVID, as you've heard from several other doctors today, has a recovery rate of well over 99%. It's not killing many people. Yet we're talking about mandating a vaccine for COVID for what? It's not even approved. It's only approved under emergency use authorization. It's absurd. So this bill would prevent that. And it would prevent discrimination based on that, based on your decision. Now, someone brought up private business, and I've changed from what I was going to testify on because I've heard a lot of stuff that I think is nonsense. Private business. I keep hearing we shouldn't regulate private business, particularly if you're on the conservative side of the aisle. Well, let me tell you what, we do. We do. You're not allowed to discriminate against people because of the color of their skin. Would you suggest that we lift that? Who would suggest that we lift anti-discrimination rules against people for religion? But that's precisely what this does. You realize that there are sects of Judaism, Christianity, Islam, pick your religion, that disagree fervently and have firmly held religious beliefs that they cannot be vaccinated. A employer that wants to discriminate based on vaccination status is doing nothing. They're discriminating against religious beliefs. Are we going to allow that? It's very clear in this country that individual rights do trump those of the collective. And that's how it should be. I'm a strong advocate for that, and I'm an unapologetic advocate for that. If you believe in this vaccine, I encourage you to do it. By the way, I'm against no other vaccine. This one is untested, and I'm against it up to the point that I think it's untested. And I can actually cite in the EUAs the admission that it's untested. I found it interesting that the Academy of Pediatrics is saying that they're for this, even though the EUAs specifically say it's untested, which would qualify as an experiment on children. We're going to experiment with this on children? Are you kidding me? That's a great idea. Not mine, though. We have to have exemptions for this vaccine. Now, I'm not commenting on any other vaccine because I don't really have a problem with vaccines in general. I do have a problem with this one. Until such time as we have the many years of testing and approval that go into this, I am absolutely not going to have anyone in my family get this if I can prevent it. And I think everybody else deserves to have that right too. And we shouldn't be discriminated against in terms of being able to go to the store because of that. Now, that discrimination, whether it be because of religion, because of medical exemptions, or because of rights of consciousness or personal choice, should apply universally. I hope that this bill does cover private business. 99.9% recovery rate does not justify discrimination at all in any way, shape, or form. If this was a disease with a 50% fatality rate like Ebola, and you said, I don't want someone with Ebola in my business, well, that would make sense. But not a disease with a 99.9% recovery rate. And I think that we need to really focus on the fact that I mentioned Ryan White. We all felt for him. People came out and they supported him, and they should. Let me tell you about a child that I know about. We had a child here in Ohio who was unable to get this vaccine for medical reasons, unable to wear masks for medical reasons, so on and so forth. This child was ostracized from his friends because everybody's been scared into believing that if you don't get this vaccine and you don't wear these masks, that, you're going to kill them, despite the fact that we've had 379 child deaths in the country. This child was so ostracized and so upset about this that he became suicidal. He's been in medical treatment ever since. We had another child, 10 years old. He's been hospitalized because he refused to swallow his own saliva or eat or take in anything that would result in him swallowing his own saliva, because he's heard us adults talking about how this is killing everybody. He's heard it so much, and he knew that it spread through things like saliva. And so he became terrified of his own saliva to the point he quit eating. He's now in the hospital. We're damaging our children. We're damaging them badly. And this legislation is important. I hope it will expand and be very clearly applied to private business, as it should be. Private business should not be able to make a decision about this. We already legislate many and regulate private business in a lot of ways. Why would we allow them to further discriminate for religious or medical reasons? And that is the only reason for a vaccine passport, by the way. A vaccine passport, it exists for no other reason than to allow for discrimination. There just simply is no other reason to have it. So I urge you to expand this bill, if anything. I urge you to ensure that people can't be discriminated against. Let's not repeat the mistakes of the early 80s with AIDS. Especially for a disease that has roughly the same recovery rate as the flu. We don't do this for the flu. We don't even do this for tuberculosis, which has a much higher death rate and is far, far more dangerous. And I don't think you have the legal authority to do it either. So thank you very much.
Okay, thank you very much. I'm going to ask all committee members to hold their questions. We still have almost a dozen speakers. There's going to be a, see my finger, 2-minute limit per speaker. We have a hard stop of 12:30 because this account has to be used by the Judiciary Committee. And I know Senator Whitley would like to have lunch. Okay, so Griffin next, and Griffin will keep the time. No questions, 2 minutes per witness.
Lisa Dean, you are up.
Hello?
Yep, we can hear you. You got 2 minutes.
Great. All right, great. Thank you, senators. My name is Lisa Dean, and I'm a member of the public, and I'm in full support of this bill. I'm a 20-year resident of New Hampshire and originally from Massachusetts. So I enjoy no income tax, no sales tax, but what I especially covet is our medical freedom in New Hampshire. I'm a parent who takes parental rights and parental consent extremely seriously. There's clear reasons why they are minors. Parents know their children's health best. Just like all of you senators who have children, you have been afforded parental rights on injections into your children's bodies their whole lives. With this bill, it is of utmost importance we're not forcing injections into bodies. That must be left to individuals and parents. An injection can't ever be taken back, ever. Look at Johnson & Johnson COVID vaccine. It's halted right now in the United States. Deciding what gets injected into bodies is a fundamental right in this country and in New Hampshire. Individuals know their bodies best and their children's bodies best. We know existing conditions. We know our health history. We know our health better than the government. Bottom line, individuals get to decide what gets injected into their bodies, in their children's bodies. No force, no coercion, none. New Hampshire is live free or die, not live free, inject and die. I urge each of you to dig deep and support this bill. Thank you.
Thank you very much. Griffin?
Next person that has signed up is, well, his hand is up now, Ken Norton. Ken, you have to unmute on your end.
Thank you, committee members, and I'll be very brief. I was not prepared for this hearing, but I did notice as a holdover from the previous hearing that it does not include a section relative to non-emergency psychiatric admissions. And I would suggest that in lines 12 through 13, that it be included to include the non-emergency admission process under RSA 135C, section 34 to 54. So that's the probate commitment process, which is an important part of the psychiatric admission process. And I'm happy to answer any questions.
Thank you, Ken. Why don't you get back to us offline on that?
Okay, thank you.
Griffin?
Next person I have signed up is Elizabeth Kenny. I'm not seeing Elizabeth in the attendees list. Elizabeth, if you're present, please raise your hand or press *9 on the phone. Otherwise, we'll continue to Jack Shemek. Jack, if you are present, please raise your hand or press *9 if you're on the phone. Not seeing him, we'll move along. Next person I have signed up is John Schmidt. John, go ahead. John?
Yes, move along.
Yep, moving along. Let's see. Next I have up is Steve Bowden. I do not see Steve Bowden in the attendees list. If he's present, please raise your hand. We already heard from Representative Cushman. I do have Randy Hebert with his hand raised. I'll call him next.
Hi, can you hear me?
Yep.
Awesome. Hi, I just wanted to call in. Unfortunately, as much as I agree with most of this bill, there's still some language in there that needs to be included. So I'm hoping that you guys can do better, and I'm in opposition of this bill at the time. Thank you.
Thank you, sir. Could we call Larry Polewski?
I do not see Larry in attendance. Oh, it's Lawrence. Got it.
Hi, good morning. Can you hear me?
Yes, sir. Thank you.
Hi, good morning. Thank you for letting me speak today. My name is Dr. Lawrence Polewski. I'm a licensed pediatrician in New York State, and I'd like to testify in support of no mandates for vaccinations or medical procedures to children and adults. You will hear with great certainty from the medical profession and the mainstream that if you vaccinate children, you will save those who are not vaccinated. And somehow unvaccinated children are blamed for outbreaks. They're blamed for carrying germs and spreading germs from one person to the next. Unfortunately, there is a lot of uncertainty about that statement. And there's a great debate about that statement. And the scientific literature actually shows that unvaccinated children are not necessarily responsible for outbreaks. There's a certainty that once you're vaccinated, you're immune. And if you're immune, you will no longer pass the germ from one person to the next. Well, in fact, there's great evidence in the scientific literature that just because you're vaccinated, it does not mean you're necessarily immune. So children who are vaccinated are also capable of spreading disease from one person to the next, but we ignore that information in the scientific literature. We are convinced with certainty that vaccines have been safely studied and are effective, and we accept that. But when we look into the scientific literature and we're told that we can't debate it, we see that there's plenty of evidence that the materials that are in the injections are actually dangerous. 1 in 5 children in this country have neurodevelopmental disabilities. 1 in 35 has autism, 1 in 10 with ADD and ADHD, and 1 in 20 under the age of 5 has seizure disorders. Whenever I've asked other pediatricians, excuse me, do vaccine ingredients enter the brains of our children causing inflammation? They ignore my question because no study has ever evaluated it. Where there is risk, there needs to be choice. And when you mandate a procedure that has not been fully scientifically evaluated, and yet we think with certainty that it has, we run the risk of creating the neuroinflammatory as well as many other chronic illnesses that we're seeing in children. There needs to be choice. We are told with certainty.
Mr. Polewski, I'm sorry, your 2 minutes are up. If you could conclude, that'd be great.
Yes, thank you for this opportunity. We are told with a lot of certainty, and yet there is a lot of uncertainty around these mandated injections. And we need to be more judicious about learning about them and debating them and bringing them into public discourse so people can learn things from their own discovery and not just from what they're told is true by one side. Thank you.
Thank you very much, sir. Could we hear next from Dr. Sobelson?
Yep.
Thank you. Can you hear me?
Yep.
Thank you. My name is Dr. Gary Sobelson, and I'm a family physician in Concord, New Hampshire. With great respect, Chairman Bradley and members of the committee, you've given a great deal of unlimited time to out-of-state physicians and alleged experts. And as representing the New Hampshire Medical Society, I would request not a prolonged amount of time, but at least enough time to complete several minutes of testimony. That, of course, is up to you. I'm here representing the New Hampshire Medical Society, a group that represents over 2,000 New Hampshire physicians. We speak in opposition to HB 220 and ask for your efforts to prevent its enactment. I've listened to testimony from out-of-state physicians this morning, contradicting experts throughout the country and in our state without an ability to really contradict. I've heard people talk about a 1% risk of transmission with a disease that has a death rate in our country of 2%, and to write that off as being unimportant. I heard an expert in Texas tell me that there were over 2,000 deaths recorded in a vaccine monitoring program, and implied to you that those were caused by the vaccine, which in fact he knows is not true. I've heard an attorney suggest that the US Constitution doesn't apply to private corporations. HB 220 professes to support the principle of medical autonomy. That is the capacity of a patient to act intentionally and voluntarily and make very important choices. But it's not balancing that autonomy with an equal and perhaps even more important principle, which is non-malfeasance. The requirement that those decisions cannot create harm or injury to others. I would also say that many of the experts you've heard have focused on this as a COVID vaccine bill. It is not. It talks about persons not accepting any medical intervention. So does it make a mask mandate illegal? Does it make a testing mandate illegal? The breadth of this bill in and of itself should concern all of you in terms of the rights and opportunities in our society. In common parlance, privileges must rightfully end your privileges must rightfully end when they impose on mine. The right of an individual to decline a medical intervention, a test, a treatment, and maybe an immunization can't override the right of a coworker, patient, or an innocent bystander to be harmed by that choice. That's the essence of what you are considering today. The famous case of Typhoid Mary, the Irish immigrant woman who worked for New York families in the early 20th century, who infected over 3,000 people and had to have her rights impugned because of the challenges to public health were there. The HIV epidemic was already incited in Ryan White. Well, the HIV epidemic was to some extent addressed through testing and through medical personnel in particular. And I remember that time because I lived through that time. We had to be careful not to spread disease that we could have gotten to our patients. More efforts, to get us back into travel, restaurants, all these activities are going to depend on us using testing, masks, and yes, immunizations. And if this bill is passed, these efforts could significantly be impaired. Immunization is a public health response, and it's very important. Our state has done one of the best jobs in the country in providing immunizations, and we lead almost in all the statistics on this for children, adults, and workers. For bills to come into place that get in the way of that are not in the public interest. It's very impossible for us to anticipate the next medical crisis that we're going to face. But it is clear to us as members of the medical society advocating for our patients that HB 220 will create major limitations on our ability to respond to a crisis. I know you all have to balance rights and privileges, and it's very hard to do. But the medical society strongly requests that you prevent the enactment of HB 220 and recognize that the rights of that person to decline any medical intervention and immunization cannot supersede the rights of the person standing next to them to live and work and maybe even attend a UNH graduation in a healthy and safe environment. Thank you very much.
Doctor, did you testify in front of the House?
I did not.
Thank you. Griffin?
Next I have up is Kelly Potenza. Kelly, if you can unmute from your end. Kelly?
Yeah,
Yep, you're free to testify. You have 2
I
minutes.
did. Can you hear me?
Yep.
Yep, I am muted.
No, we hear you.
Yes, so, I was first in, of course, very strong support. Do you hear me?
You're sort of breaking up, but keep trying.
Hello?
You know what, Griffin? Why don't we go to the next person? I think she's having internet problems. Go back
Am
to.
I on?
Kelly, we'll come back to you. Next person I have signed up is, let's see. Oh, I'm sorry, Representative Judy Aaron.
Representative, good morning or good afternoon.
Yes, good afternoon. First of all, I want to thank you all for patiently listening to all the people testifying. I hope you can hear me well.
Go ahead.
Well, I'm Judy Aaron, Representative Judy Aaron from Sullivan County, District 7, representing Ackworth, Goshen, Langdon, Leominster, and Washington. And I'm just be very brief. With regard to vaccination and any medical treatment, I believe people should have the choice. And that choice should be free from anyone being ostracized in our society. We always hear people saying, my body, my choice. And I believe that's true, my body, my choice. And I should not be shunned or punished for my choice. So I just want to reiterate that it's important that people be able to make their own medical decisions and not be punished by society by not being able to say, go shopping or fly an airplane or, go anywhere or do anything just because they've made a certain medical choice, which they consider very importantly, very passionately for themselves and their family. We should not be placing all these different roadblocks into bullying them into doing something that they don't want to do. So I just would like to add that. And again, I really appreciate you listening to everybody this morning. It's a difficult subject, but I think it's really important that we really consider that people need to have a choice as to what they want to do with their medical decisions and not be bullied by government or institutions or society into doing something that they truly believe they don't want to do. Thank you.
Great. Thank you very much, Representative Griffin.
Next person I have signed up to speak is Thomas Peets, but I do not see him in the attendees list. Tom, if you are in attendance, please raise your hand and we'll come back to you. Next up, I have Thomas McLeod.
Yes, can you hear me?
Yep.
Thank you, Mr. Chairman and members of the committee. My name is Thomas McLeod. I'm a resident of Mount Vernon, New Hampshire, and the chair of the Liberty Defense Fund in New Hampshire and the member of the leadership group in Health Freedom New Hampshire, testifying today as a member of the public. I had a prepared testimony on the history of the of informed consent, starting with the Nuremberg Code. But due to the limitations of time, I'll submit that testimony as written testimony. I would like to point out that over the progression of several decades since the Nuremberg Code was established in 1947, there have been quite a number of advancements in the field of informed consent that undermine the primary U.S. Supreme Court decision in Jacobson versus Massachusetts, which ostensibly gives states the right to mandate vaccines. Terminating this list, this long list of advancements, on January 27, 2021, the Parliamentary Assembly of the Council of Europe issued Resolution 2361, which states in its pertinent part that member states shall ensure that citizens are informed that vaccination, and this is particularly about COVID-19, that the vaccination is not mandatory, that no one is politically, socially, or otherwise pressured to get themselves vaccinated. If they do not wish to do so themselves. And member states are also required to ensure that no one is discriminated against for not having been vaccinated due to possible health risk or not wanting to be vaccinated. And the Council of Europe is the preeminent international organization founded in the wake of World War II to uphold human rights, democracy, and rule of law in Europe. It has 47 member states.
Could you confine the remainder of your time to the bill itself, please?
Yes, I think I'll conclude there, Senator, and submit the rest of the testimony I have as written.
I'm sorry, but we have a hard stop and we still have a couple of more people to testify. I'm sorry.
Thank you.
Okay, Griffin, let's have Laura Condon.
Yep.
Good afternoon. Can you hear me?
Hi, Laura.
Hi, Jeb. Senator Bradley, how are you?
Jeb works better.
Yes. Thank you for the opportunity to speak. My name is Laura Condon. I'm from Bedford, and I'm a volunteer director of advocacy with the National Vaccine Information Center. And as such, I have a great deal of contact with public health and with members of the public on vaccine issues. I'm here today in support of House Bill 220. I wish to point out that there have been reported through the VAERS program 2,342 COVID vaccine deaths now reported. Although we know many fail to report, we know this is the tip of the iceberg. The first COVID vaccine death reported in New Hampshire was on January 4th, 2021 in a 44-year-old woman. The first Johnson & Johnson vaccine death reported in New Hampshire was on March 9th, 2021 due to a blood disorder called idiopathic capillary leak syndrome. This was a full 35 days before that vaccine was taken off the market here in New Hampshire. Why was the public not notified? It is not just in 6 people. VAERS reports show 388 reports of blood clot, blood vessel, blood disorder issues through April 1st. Then there is vaccine failure. Although there is claim that only 3 people have reported breakthrough cases, that flies in the face of what even Governor Sununu has reported in his public press release when he said that there were 7 reported deaths in Manchester nursing homes and patients who were fully vaccinated. Why aren't we getting accurate information from our public health department? Also, there is claim that nurses have a choice to wear a mask if they don't wish to vaccinate. That is not true. I'm working with a nurse who works electronically. She was fired from her job, even though she has 0 patient contact, for declining a flu shot. There should be choices. Vaccines are not the only way to address this crisis and are likely not the best way. There's lifestyle risks that we need to mitigate. Public health could help with that effort. There are treatment options that should be promoted. COVID is, as we've heard, COVID is not a death sentence. The claim of safe and effective is denial of facts and reality. I wish to add that there is a high voluntary use of vaccines in New Hampshire in schools. 73% of vaccines that children get in New Hampshire are on a voluntary basis. They are for vaccines that are not required. That was reported by Beth Daly to the New Hampshire Vaccine Association. There is a 73.5% flu shot use in adults on a voluntary basis. Voluntary vaccine use works. We do not have a problem. There is not a requirement for mandates, and it is essential to protect medical choice. Thank you for your time, and I do hope you will support this bill.
Thank you, Laura.
Thank you.
The only other person I have, Senator, is John Schmidt, who we tried earlier. I'll try him one more time.
And what about the person that had
I was gonna look for her after John Schmidt.
the internet?
Can you hear me? Can you hear
Yes.
me?
Good afternoon, sir.
Thank you for giving me the time to get my computer straightened out.
No worries.
There was a lot of stuff discussed, which I agree with. I support the bill, although I'd like to see a stronger bill that would protect me from having a normal lifestyle without a vaccine passport like communist China is pushing. We don't really need that in New Hampshire. But one point I like to make is all these vaccines, and I'll never get one, but they're all based on the germ theory of disease. Germ theory of disease never has been proven for any disease. It's the terrain theory of disease that is correct. Terrain theory says it's poisons and or a lack of nutrition that causes disease, and that's the truth. I'll give you a few examples. Scurvy, deficiency of vitamin C, not a virus. Polio, not a virus. That was lead arsenate insecticide and DDT insecticide that caused polio. No one's ever isolated no polio virus, no HIV virus, no COVID virus. This is all nonsense. To prove it, that any of these viruses or bacteria causing disease, you've got to scientifically use Koch's postulates or Rivers postulates. Never been done for any disease. So trying to push these deadly vaccines on people is completely wrong. Thank you.
Thank you very much, Mr. Schmidt. Representative Lang has asked for a brief opportunity to speak again.
Sure, and Senator, just to clarify, Kelly, who we tried calling earlier, I don't even see her in the attendees list, but Kelly, if you're here, please raise your hand and we'll come back to you.
Go ahead to Representative Lang.
Yeah, I'm looking for him. Hold on. Oh, I think I muted him.
Thank you, Senator. I'm here. Can you hear me okay?
Yep, go ahead, Representative.
Great. Whoever had that square on Zoom bingo just got it checked off. So I guess I just want to make a last statement, is just to remind that this bill is not going to affect vaccination rates, in my opinion, at all. We currently don't have mandatory vaccination rates standards in the state of New Hampshire, and we have a high percentage of people who get vaccinated anyway. So this is about protecting the individual who chooses not to get vaccinated. And that's really the focus of this bill, is about the individual who chooses not to. This is not about creating mandatory mandates that we currently don't use anyway. And talking to Beth Daly and the rest of the people over at DHHS, it doesn't seem to be a mandate, but it's protecting that individual who chooses not to get a vaccination. And I think that's probably the most key factor as we talk about this, is, again, focusing on that individual who chooses to exercise a right, informed consent, as doctors talk about all the time. I get to make the choice after being informed of what's going on. And I think someone said it best, is that where there's a risk, there should be a choice. And that's what this bill is about. It's about allowing the individual to weigh the risk and make the choice. And I just urge you to support the bill, and I'll be happy to work with the committee on any changes they might want to make. I know there's been some really good discussion here, and I hope you do move forward with this bill.
Thank you, Representative. One quick question. Given the testimony that we've heard from New Hampshire Medical Society, Beth Daly of the Department of Health and Human Services, and all of the discussion around the COVID vaccine, what would be your thoughts if the Senate were to make this about the COVID-19 vaccines and leave the rest of the discussion about medical intervention and other vaccines for another day?
So again, Senator, if that's what you choose to do, I would not, I'll take what I can get. I'm a big believer in compromise and making sure we get what we need to get. But I do think that that's just going to make us have to keep revisiting this general concept of medical integrity, bodily integrity, that we'll need to come back to it again and again. And so I think that establishing the basic core principle that we have a right to our own bodily integrity is key. And then if we want to add something to call out COVID, I think that could be appropriate. But I do think that, again, that core principle that each person has where there's risk, there should be choice. And state shouldn't mandate that and force us in. So I think that's probably my greatest statement.
Okay, thank you, Senator Whitley.
So Representative Lang, I remain perplexed about the need for this bill when we don't have a vaccine mandate. We do not have a vaccine passport. There's not one bill that attempts to do so, nor has our governor indicated that he wants to do that. So what is the purpose of this bill? It's trying to solve a problem that doesn't exist?
Thank you for the question. But again, I think if you need merely turn on your TV and see the national conversation about what's going on about COVID passports and requirements. It's not. I don't think it's a big stretch to see that there's a potential future there, and that this bill is a forward-looking bill to prevent those kind of forward-looking events. And on top of that, again, I go back to my conversation around what happened over in Jalkar with foster parents. We saw a move specifically by the state to mandate vaccines for a group of individuals within a state that could have a religious exemption, and ignoring that religious exemption. Again, I could see where if you had a child who had compromised immune system, the state could mandate that particular child that the foster family it goes to, and everybody in that house has to be vaccinated. But to extend that beyond a healthy child who's fully vaccinated and being brought into a foster family, and the state saying, we don't care, that family has to be vaccinated. So I do see a cause for this. I do see a causation. I see some religious issues there, and that religious rights issues that we've just thrown away. So yes, I do see a need for this. I do see that the state has taken its first step in the foster family program, where not making it a case-by-case basis, but making a mandate across the entire system of foster care. So again, yes, I see tea leaves that I don't like, and I see steps being taken by, again, DHHS and making a mandate under the foster care family that is the predicate or beginning of more mandates.
Okay. I just don't know if we should be legislating based on reading tea leaves. I mean, maybe that's just me.
It's not a tea leaf, Senator, to read that they did in fact make a mandate on foster families. That's what they did. So it's not a tea leaf, and I just believe that's the first step.
Okay. We're at 12:26. I don't think there are any further people to testify. Thank you very much, Representative Lang. I'm going to close the hearing. Committee, I had made a commitment to, I think, Representative Josephson to exempt House Bill 240 today. Do we want to do that quickly? I don't see any reason that we couldn't do it and still be off by 12:26, 12:30, I mean.
Move to go into executive session.
Identification of cannabis strains for therapeutic cannabis. There was no opposition to it in the hearing. What's the will of the committee?
Move to go into executive session.
Second. All right, Senator Gray has moved that we go into executive session, seconded by Senator Avard. I'll call the roll. Senator Whitley.
Yes.
Senator Sherman.
Yes.
Senator Avard.
Yes.
Senator Gray.
Yes.
I vote yes. Okay, is there a motion of ought to pass on House Bill 240?
So moved.
Moved by Senator Avard.
Second.
Seconded by Senator Gray. Any discussion? Seeing none, I'll call the roll. Senator Sherman,
Yes.
Senator Whitley,
Yes.
Senator Avard,
Yes.
Senator Gray.
Yes.
I vote yes. Is there a subsequent motion?
Move to consent?
Senator Avard moves to consent. Senator Sherman seconds. Senator Gray,
Yes.
Senator Avard,
Yes.
Senator Whitley,
Yes.
Senator Sherman.
Yes.
I vote yes, and I will take it out to make it easier.
Move to come out of executive session.
Second?
Senator Avard,
Yes.
Senator Sherman,
Yes.
Senator Gray,
Yes.
Senator Whitley.
Yes.
I vote yes, and Senator Whitley, you have 31 minutes for lunch, and we're done by 12:30.
Thank you very much.
Oh, we have to motion to adjourn.
Motion
Senator Gray
to
moves
adjourn.
Seconded by Sherman. Senator Gray,
Yes.
Senator Sherman,
Yes.
Senator Avard,
Yes.
Senator Whitley,
Yes.
and I vote yes. Thank you, Griffin. Thank you, Kirsten. Sorry for the rush nature. It is what it is.